All right, now we're going to go and read about Chapter 41. Oxygenation is going to go with our Module 3 gas exchange. So we're going to read through here, figure out what's important, go over that, and yeah, it should be good. So we're going to start somewhere around wherever it says nursing stuff. Screw all that. Here it is. Let's do it.
Nursing knowledge base. Factors influencing oxygenation. In addition to physiological factors, multiple developmental, lifestyle, and environmental factors affect patients' oxygenation status. It is important to recognize these as possible risks or factors that impact their healthcare goals. Developmental factors. The developmental stage of a patient and the normal aging process affect tissue oxygenation. Infants and toddlers. Infants and toddlers are at risk for upper respiratory tract infections as a result of frequent exposure to other children, an immature immune system, and exposure to second-hand smoke. In addition, during the teething process some infants develop nasal congestion, which encourages bacterial growth and increases the potential for respiratory tract infection. Upper respiratory tract infections are usually not dangerous, and infants or toddlers recover with little difficulty. School-age children and adolescents. School-age children and adolescents are exposed to respiratory infections and respiratory risk factors such as cigarette smoking or second-hand smoke. A healthy child usually does not have adverse pulmonary effects from respiratory infections. The CDC, 2013b, reported that 6.7% of middle school-age children and 23.3% of high school-age children currently use tobacco products, which include cigarettes, cigars, hookahs, snus, smokeless tobacco pipes, biddies, keeks, dissolvable tobacco, and electronic cigarettes, CDC, 2013b. Current cigarette smoking among middle school and high school age children has declined. 9 out of 10 smokers started smoking by the age of 18, and 99% started by the age of 26, CDC, 2014c. A person who starts smoking in adolescence and continues to smoke into middle age has an increased risk for cardiopulmonary disease and lung cancer. Young and middle-age adults. Young and middle-age adults are exposed to multiple cardiopulmonary risk factors: an unhealthy diet, lack of exercise, stress, over-the-counter and prescription drugs not used as intended, illegal substances, and smoking. Reducing these modifiable factors decreases a patient's risk for cardiac or pulmonary diseases. This is also the time when individuals establish lifelong habits and lifestyles. It is important to help your patients make good choices and informed decisions about their healthcare practices. The increased cost of cigarettes plus the state smoke-free air policies and laws that reduce smoking in public places have proven to be helpful in smoking cessation, CDC, 2012. Older adults. The cardiac and respiratory systems undergo changes throughout the aging process, box 41-1. The changes are associated with calcification of the heart valves, SA node, and costal cartilages. The arterial system develops atherosclerotic plaques. Box 41-1. Focus on older adults. Cardiopulmonary implication in older adults. The tuberculin skin test is an unreliable indicator of tuberculosis in older patients. They frequently display false positive or false negative skin test reactions. Older patients are at an increased risk for reactivation of dormant organisms that were present for decades as a result of age-related changes in the immune system. The standard 5-2 Mantoux test is given and repeated with the 252 strength to create a booster effect. If the older patient has a positive reaction, a complete history is necessary to determine any risk factors. Cardiac problems differ from other chronic conditions in that, when they become acute, symptoms worsen rapidly and necessitate hospitalization, whereas other chronic conditions can be managed in the home. Tui and Jet, 2014. Controlling blood pressure in older adults results in 30% fewer strokes, 64% heart failure, 23% fewer fatal cardiac events, and 21% fewer cardiac-related deaths. Tui and Jet, 2014. Mental status changes are often the first signs of cardiac and/or respiratory problems and often include forgetfulness and irritability. Changes in the older adult's cough mechanism lead to retention of pulmonary secretions, airway plugging, and atelectasis if patients do not use cough suppressants with caution. Age-related changes in the immune system lead to a decline of both cell-mediated and humoral immunity, resulting in an increased risk of respiratory infections. McCants and Huther, 2014. Changes in the thorax that occur from ossification of costal cartilage, decreased space between vertebrae, and diminished respiratory muscle strength lead to problems with chest expansion and oxygenation. Tui and Jet, 2014. Osteoporosis leads to changes in the size and shape of the thorax. The trachea and large bronchi become enlarged from calcification of the airways. The alveoli enlarge, decreasing the surface area available for gas exchange. The number of functional cilia is reduced, causing a decrease in the effectiveness of the cough mechanism, putting the older adult at increased risk for respiratory infections. Tui and Jet, 2014. Lifestyle factors. Lifestyle modifications are difficult for patients because they often have to change an enjoyable habit such as cigarette smoking or eating certain foods. Risk factor modification is important and includes smoking cessation, weight reduction, a low cholesterol and low sodium diet, management of hypertension, and moderate exercise. See Chapter 6. Although it is difficult to change long-term behavior, helping patients acquire healthy behaviors reduces the risk for or slows or halts the progression of cardiopulmonary diseases. Nutrition. Nutrition affects cardiopulmonary function in several ways. Severe obesity decreases lung expansion, and increased body weight increases tissue oxygen demands. The malnourished patient experiences respiratory muscle wasting, resulting in decreased muscle strength and respiratory excursion. Cough efficiency is reduced secondary to respiratory muscle weakness, putting a patient at risk for retention of pulmonary secretions. Patients who are morbidly obese and/or malnourished are at risk for anemia. Diets high in carbohydrates play a role in increasing the carbon dioxide load for patients with carbon dioxide retention. As carbohydrates are metabolized, an increased load of carbon dioxide is created and excreted via the lungs. Dietary practices also influence the prevalence of cardiovascular diseases. Cardioprotective nutrition includes diets rich in fiber, whole grains, fresh fruits and vegetables, nuts, antioxidants, lean meats, fish and chicken, and omega-3 fatty acids. Restriction of sodium, controlling arterial pressure, and weight loss independently facilitate the regression of left ventricular hypertrophy. Cathali and Curry, 2011. Diets high in potassium prevent hypertension and help improve control in patients with hypertension. A 2,000-calorie diet of fruits, vegetables, and low-fat dairy foods that are high in fiber, potassium, 880 calcium, and magnesium and low in saturated and total fat helps prevent and reduce the effects of hypertension. Exercise. Exercise increases the metabolic activity and oxygen demand of the body. The rate and depth of respiration increase, enabling the person to inhale more oxygen and exhale excess carbon dioxide. A physical exercise program has many benefits, see Chapter 39. People who exercise for 30 to 60 minutes daily have a lower pulse rate and blood pressure, decreased cholesterol level, increased blood flow, and greater oxygen extraction by working muscles. Fully conditioned people increase oxygen consumption by 10% to 20% because of increased cardiac output and increased efficiency of the myocardial muscle. James et al., 2014. Smoking. Cigarette smoking and second-hand smoke are associated with a number of diseases, including heart disease, COPD, and lung cancer. Cigarette smoking worsens peripheral vascular and coronary artery diseases. McCants and Huther, 2014. Inhaled nicotine causes vasoconstriction of peripheral and coronary blood vessels, increasing blood pressure and decreasing blood flow to peripheral vessels. Women who take birth control pills and smoke cigarettes have an increased risk for thrombophlebitis and pulmonary emboli. Smoking during pregnancy can result in low birth weight babies, preterm delivery, and babies with reduced lung function. CDC, 2014F. Even exposure to second-hand smoke can be a risk for low birth weight babies, preterm delivery, and miscarriages. CDC, 2014F. The risk of lung cancer is 10 times greater for a person who smokes than for a non-smoker. In the United States, the use of tobacco accounts for 30% of all cancer deaths. This includes 87% of the deaths from lung cancer and cancer of the larynx, mouth, pharynx, esophagus, and bladder. Smoking has been linked to the development of other cancers, including kidney, cervix, and leukemia. ACS, 2014A. Nicotine patches, gum, and lozenges are available over the counter, and nicotine nasal spray and inhalers can be obtained by prescription. Prescription drugs such as bupropion, Zyban, and varenicline, Chantix, are also available to help people quit smoking. ACS, 2014B. Exposure to environmental tobacco smoke, second-hand smoke, increases the risk of lung cancer and cardiovascular disease in the non-smoker. Children with parents who smoke have a higher incidence of asthma, pneumonia, and ear infections. Babies exposed to second-hand smoke are at higher risk for sudden infant death syndrome. ACS, 2014A. Substance abuse. Excessive use of alcohol and other drugs impairs tissue oxygenation in two ways. First, the person who chronically abuses substances often has a poor nutritional intake. With the resultant decrease in intake of iron-rich foods, hemoglobin production declines. Second, excessive use of alcohol and certain other drugs depresses the respiratory center, reducing the rate and depth of respiration and the amount of inhaled oxygen. Substance abuse by either smoking or inhaling substances such as crack cocaine or fumes from paint or glue cans causes direct injury to lung tissue that leads to permanent lung damage. Stopler, 2013. The report on inhalant abuse, huffing, by teenagers to get a euphoric effect includes use of a wide variety of substances such as paint thinner, nail polish remover, glue, spray paint, nitrous oxide, and other common household products. Sudden death can occur from cardiac arrhythmias, or chronic abuse can cause damage to heart, lungs, and kidneys. Stopler, 2013. Stress. A continuous state of stress or severe anxiety increases the metabolic rate and oxygen demands of the body. The body responds to anxiety and other stresses with an increased rate and depth of respiration. Most people adapt, but some, particularly those with chronic illnesses or acute life-threatening illnesses such as an MI, cannot tolerate the oxygen demands associated with anxiety. See Chapter 38. Environmental factors. The environment influences oxygenation. The incidence of pulmonary disease is higher in smoggy, urban areas than in rural areas. In addition, a patient's workplace sometimes increases the risk for pulmonary disease. Occupational pollutants include asbestos, talcum powder, dust, and airborne fibers. For example, farm workers in dry regions of the southwestern United States are at risk for coccidioidomycosis, a fungal disease caused by inhalation of spores of the airborne bacterium Coccidioides immitis. Asbestosis is an occupational lung disease that develops after exposure to asbestos. The lung with asbestosis often has diffuse interstitial fibrosis, creating a restrictive lung disease. Patients exposed to asbestos are at risk for developing lung cancer, and this risk increases with exposure to tobacco smoke. Critical thinking. Successful critical thinking requires a synthesis of knowledge, experience, information gathered from patients, critical thinking attitudes, and intellectual and professional standards. Clinical judgments require you to anticipate information, analyze the data, and make decisions regarding your patient's care. During assessment, consider all elements that build toward making an appropriate nursing diagnosis. Figure 41-6. Figure 41-6 Critical Thinking Model for Oxygenation Assessment. To understand how alterations in oxygenation affect patients and your selection of appropriate interventions, you need to integrate knowledge from nursing and other disciplines and information gathered from patients. Critical thinking attitudes ensure that you approach patient care in a methodical and logical way. The use of professional standards such as those developed by the Centers for Disease Control and Prevention, CDC, the American Cancer Society, ACS, the American Heart Association, AHA, the American Lung Association, ALA, the American Thoracic Society, ATS, and the American Nurses Association, ANA, provide valuable guidelines for care and management of patients. Nursing process. Apply the nursing process and use a critical thinking approach in your care of patients. The nursing process provides a clinical decision-making approach for you to develop and implement an individualized plan of care. Assessment. During the assessment process, thoroughly assess each patient and critically analyze findings to ensure that you make patient-centered clinical decisions required for safe nursing care. Nursing assessment of cardiopulmonary functioning includes an in-depth history of a patient's normal and present cardiopulmonary function, past impairments in circulatory or respiratory functioning, and methods that a patient uses to optimize oxygenation. The nursing history includes a review of drug, food, and other allergies. Physical examination of a patient's cardiopulmonary status reveals the extent of existing signs and symptoms. Utilizing assessment values of pulse oximetry and capnography aids in the assessment of patients with spontaneous breathing, intubated patients, and patients requiring oxygen therapy or mechanical ventilation. Pulse oximetry provides an instant feedback about the patient's level of oxygenation. Capnography, also known as end-tidal CO2 monitoring, provides instant information about the patient's ventilation, how effectively CO2 is being eliminated by the pulmonary system, perfusion, how effectively CO2 is being transported through the vascular system, and how effectively CO2 is produced by cellular metabolism. Erden et al., 2014. Capnography is 881 measured near the end of exhalation. Finally, a review of laboratory and diagnostic test results provides valuable assessment data. Through the patient's eyes. Ask patients about their priorities and what they expect from their healthcare visit. Identifying their expectations involves patients in the decision-making process and helps them participate in their care. For example, planning a smoking cessation program for a patient who is not ready for the change is frustrating for both the patient and the nurse. Establish realistic, short-term outcomes that build to a larger goal. For example, tobacco cessation treatments are effective, but a patient needs to be willing to participate in the program and may need to use several strategies to be successful. Educating the patient on the opportunities for individual, group, or telephone counseling and identifying a social support system give more individual choices when developing the cessation plan. After this is determined, the various nicotine and non-nicotine medications for treatment of tobacco dependence can be discussed to find one that may fit the patient's lifestyle. A combination of counseling and medication is more effective than either one alone. CDC, 2014c. Remember that your goals and expectations do not always coincide with those of your patient. By addressing a patient's concerns and expectations, you establish a relationship that addresses other healthcare goals and expected outcomes. Knowing your patient's mindsets and respecting their wishes goes a long way in helping them make significant beneficial lifestyle changes. Nursing history. The nursing history focuses on the patient's ability to meet oxygen needs. The nursing history for respiratory function includes the presence of a cough, shortness of breath, dyspnea, wheezing, pain, environmental exposures, frequency of respiratory tract infections, pulmonary risk factors, past respiratory problems, current medication use, and smoking history or second-hand smoke exposure. The nursing history for cardiac function includes pain and characteristics of pain, fatigue, peripheral circulation, cardiac risk factors, and the presence of past or concurrent cardiac conditions. Ask specific questions related to cardiopulmonary disease. Box 41-2. Box 41-2. Nursing assessment questions. Nature of the cardiopulmonary problem. What types of breathing problems are you having? Describe the problem that you're having with your heart. Does the problem, example chest pain, rapid heart rate, occur at a specific time of the day, during or after exercise, or all the time? If you have chest pain, what relieves or makes the pain worse? Signs and symptoms. How has your breathing pattern changed? Do you have sputum with coughing? Is this different in color, volume, or thickness? If you have chest pain, does the pain occur with breathing? Onset and duration. If you are having chest pain, what causes the pain and how long does it last? Is this a different type of pain? When did you notice your sputum change in color and amount? When did your coughing increase? How does this differ from your usual pattern of coughing? Severity. On a scale of 0 to 10, with 10 being the most severe, rate your shortness of breath. What helps relieve your shortness of breath? On a scale of 0 to 10, with 0 being no pain and 10 the most severe pain, rate your chest pain. Is the severity of your pain different today? What do you do for this pain? Predisposing factors. Have you been exposed to a cold or flu? Are you taking your prescribed medications? Do you smoke? Have you been exposed to second-hand smoke? Have you been doing any unusual exercises? Effect of symptoms. Do any of your symptoms affect your daily activities? If so, how? How do your symptoms affect your appetite, sleeping habits, and activity status? Pain. The presence of chest pain requires an immediate thorough assessment, including location, duration, radiation, and frequency. In addition, it is important to note any other symptoms associated with chest pain, such as nausea, diaphoresis, extreme fatigue, or weakness. Cardiac pain does not occur with respiratory variations. Chest pain in men is most often on the left side of the chest and radiates to the left arm. Chest pain in women is much less definitive and is often a sensation of breathlessness, jaw or back pain, nausea, and fatigue. AHA, 2015. Pericardial pain results from inflammation of the pericardial sac, occurs on inspiration, and does not usually radiate. Pleuritic chest pain results from inflammation of the pleural space of the lungs. The pain is peripheral and radiates to the scapular regions. Inspiratory maneuvers such as coughing, yawning, and sighing worsen pleuritic chest pain. Patients usually describe it as knife-like, lasting from a minute to hours and always in association with inspiration. Musculoskeletal pain is often present following exercise, rib trauma, and prolonged coughing episodes. Inspiration worsens this pain, and patients often confuse it with pleuritic chest pain. Fatigue. Fatigue is a subjective sensation in which a patient reports a loss of endurance. Fatigue in the patient with cardiopulmonary alterations is often an early sign of a worsening of the chronic underlying process. To provide an objective measure of fatigue, ask the patient to rate it on a scale of 0 to 10, with 10 being the worst level and 0 representing no fatigue. Dyspnea. Dyspnea is associated with hypoxia. It is the subjective sensation of difficult or uncomfortable breathing. Dyspnea is shortness of breath usually associated with exercise or excitement, but in some patients it is present without any relation to activity or exercise. It is associated with many conditions such as pulmonary diseases, cardiovascular diseases, neuromuscular conditions, and anemia. In addition, it occurs in the pregnant woman in the final months of pregnancy. Finally, environmental factors such as pollution, cold air, and smoking also cause or worsen dyspnea. Dyspnea is associated with exaggerated respiratory effort, use of the accessory muscles of respiration, nasal flaring, and marked increases in the rate and depth of respirations. The use of a visual analog scale, VAS, helps patients objectively assess their dyspnea. The VAS is a 100 mm vertical line. Have patients rate their dyspnea on a scale of 8,820 to 10, with 0 equated with no dyspnea and 10 equated with the worst breathlessness a patient has experienced. The use of the VAS to assess the level of a patient's dyspnea is helpful in later evaluating interventions designed to reduce dyspnea. Pang et al., 2014. When gathering information about a patient's sensation of dyspnea, ask the patient when the dyspnea occurs, such as with exertion, stress, or respiratory tract infection, and what improves the dyspnea, example rest, inhaled medication, or position change. Determine whether the patient's dyspnea affects the ability to lie flat. Orthopnea is an abnormal condition in which a patient uses multiple pillows when reclining to breathe easier or sits leaning forward with arms elevated. The number of pillows used usually helps to quantify the orthopnea, example 2 or 3 pillow orthopnea. Also ask if the patient must sleep in a recliner chair to breathe easier. Cough. Cough is a sudden, audible expulsion of air from the lungs. The person breathes in, the glottis is partially closed, and the accessory muscles of expiration contract to expel the air forcibly. Coughing is a protective reflex to clear the trachea, bronchi, and lungs of irritants and secretions. Patients with a chronic cough tend to deny, underestimate, or minimize their coughing, often because they are so accustomed to it that they are unaware of its frequency. Patients with chronic sinusitis usually cough only in the early morning or immediately after rising from sleep. This clears the airway of mucus resulting from sinus drainage. Patients with chronic bronchitis generally cough and produce sputum all day, although greater amounts are produced after rising from a semi-recumbent or flat position. If a patient has a cough, determine how frequently it occurs and whether it is productive or non-productive. A productive cough results in sputum production, example material coughed up from the lungs that a patient swallows or expectorates. Sputum contains mucus, cellular debris, microorganisms, and sometimes pus or blood. Collect data about the type and quantity of sputum. Instruct patients to try to cough up some sputum and not to simply clear the throat, which produces only saliva. Have the patient cough into a specimen cup. Inspect the sputum for color such as green or blood-tinged, consistency such as thin or thick, odor such as none or foul, and amount in tablespoons or milliliters. If hemoptysis, bloody sputum, is present, determine if it is associated with coughing and bleeding from the upper respiratory tract, sinus drainage, or the gastrointestinal tract, hematmesis. Hemoptysis has an alkaline pH, and hematmesis has an acidic pH, thus pH testing of the specimen may help to determine the source. McCants and Huether, 2014. Describe hemoptysis according to amount and color and whether it is mixed with sputum. When there is bloody or blood-tinged sputum, healthcare providers frequently perform diagnostic tests such as examination of sputum specimens, chest X-ray examinations, bronchoscopy, and other X-ray film studies. Studies. Wheezing. Wheezing is a high-pitched musical sound caused by high-velocity movement of air through a narrowed airway. It is associated with asthma, acute bronchitis, or pneumonia. It occurs during inspiration, expiration, or both. Determine if there are any precipitating factors such as respiratory infection, allergens, exercise, or stress. Environmental exposures. Environmental exposure to inhaled substances is closely linked with respiratory disease. Investigate exposures in the patient's home, workplace, and recent travel. The most common environmental exposures in the home are cigarette smoke, CO, and radon, EPA, 2014. In addition, determine whether a patient who is a non-smoker is exposed to second-hand smoke. Co-poisoning often results from a blocked furnace flue or fireplace. The patient will have vague complaints of general malaise, flu-like symptoms, and excessive sleepiness. Patients are particularly at risk in the late fall when they turn the furnace on or begin to use the fireplace again. Radon gas is a radioactive substance from the breakdown of uranium in soil, rock, and water that enters homes through the ground or well water. When homes are poorly ventilated, this gas is unable to escape and becomes trapped. If a patient who smokes also lives in a home with a high radon level, the risk for lung cancer is very high. EPA, 2014. Ask if there are any CO or radon detectors in the home. Smoking. It is important to determine patients' direct and secondary exposure to tobacco. Ask about any history of smoking, include the number of years smoked and the number of packages smoked per day. This is recorded as pack year history, packages per day times years smoked. For example, if a patient smoked 2 packs a day for 20 years, the patient has a 40-pack year history. Determine exposure to second-hand smoke, because any form of tobacco exposure increases a patient's risk for cardiopulmonary diseases. Respiratory infections. Obtain information about a patient's frequency and duration of respiratory tract infections. Although everyone occasionally has a cold, for some people it results in bronchitis or pneumonia. On average, patients have 4 colds per year. Determine 883 if and when a patient has had a pneumococcal or influenza, flu, vaccine. This is especially important when assessing older adults because of their increased risk for respiratory disease. Tui and Jet, 2014. Ask about any known exposure to tuberculosis, TB, and the date and results of the last tuberculin skin test. Determine a patient's risk for human immunodeficiency virus, HIV, infection. Patients with a history of intravenous, drug use and multiple unprotected sex partners are at risk of developing HIV infection. Patients do not always display symptoms of HIV infection until they present with pneumocystis carinii pneumonia, PCP, or mycoplasma pneumonia. Allergies. Inquire about your patient's exposure to airborne allergens, example pet dander or mold. The allergic response is often watery eyes, sneezing, runny nose, or respiratory symptoms such as cough or wheezing. When obtaining information, ask specific questions about the type of allergens, response to these allergens, and successful and unsuccessful relief measures. In addition, determine the effect of environmental air quality and second-hand smoke exposure on the patient's allergy and symptoms. Safe nursing practice also includes obtaining information about food, drug, or insect sting allergies on the initial history and physical. However, always double-check this information with the patient on any subsequent assessment, especially concerning respiratory allergens. Health risks. Determine familial risk factors such as a family history of lung cancer or cardiovascular disease. Documentation includes blood relatives who had cardiopulmonary disease and their present level of health or age at time of death. Other family risk factors include the presence of infectious diseases, particularly TB. Medications. Another component of the nursing history describes all medications that a patient is using. These include prescribed medications, over-the-counter medications, folk medicine, herbal medicines, alternative therapies, and illicit drugs and substances. Some of these preparations have adverse effects by themselves or because of interactions with other drugs. For example, a person using a prescribed bronchodilator drug decides to use an over-the-counter inhalant as well. Many of these contain ephedrine or mahuang, a natural ephedrine, which acts like epinephrine. This product reacts with the prescribed medication by potentiating or decreasing the effect of the prescribed medication. Patients taking warfarin, Coumadin, for blood thinning prolong the prothrombin time, PT/international normalized ratio, INR, results if they are taking ginkgo biloba, garlic, or ginseng with the anticoagulant. The drug interaction can precipitate a life-threatening bleed. It is important to determine if a patient uses illicit drugs. Illicit drugs, particularly inhaled opioids, which are often diluted with talcum powder, cause pulmonary disorders resulting from the irritant effect of the powder on lung tissues. Marijuana is usually smoked in the form of a joint or pipe. Marijuana smoke contains carcinogens and is an irritant to the lungs, putting users at higher risk for lung cancer and respiratory illnesses. NIDA, 2014. Cocaine is snorted through the nose, smoked, or injected. Cocaine abusers can have acute cardiovascular changes such as constricted blood vessels and increased heart rate and blood pressure, which increases the risk for heart attack or stroke. Cocaine deaths are caused by cardiac arrest and respiratory failure. NIDA, 2013. As with all medications, assess the patient's knowledge and ability to self-administer medications correctly. See Chapter 32. Of particular importance is the assessment that the patient understands the potential side effects of medications. Patients need to recognize adverse reactions and be aware of the dangers in combining prescribed medications with over-the-counter drugs. Physical examination. The physical examination includes assessment of the cardiopulmonary system. See Chapter 31. Give special consideration when assessing an older adult patient for changes that occur with the aging process. Table 41:1. These changes affect the patient's activity tolerance and level of fatigue or cause transient 884 changes in vital signs and are not always associated with a specific cardiopulmonary disease. Table 41:1. Effects of aging on assessment findings of the cardiopulmonary system. Function. Pathophysiological change. Key clinical findings. Heart. Muscle contraction. Thickening of the ventricular wall, increased collagen, and decreased elastin in the heart muscle. Decreased cardiac output. Diminished cardiac reserve. Blood flow. Heart valves become thicker and stiffer, more often in the mitral and aortic valves. Systolic murmur. Conduction system. SA node becomes fibrotic from calcification, decrease of number of pacemaker cells in SA node. Increased PR, QRS, and QT intervals, decreased amplitude of QRS complex. Irregular heart rhythm. Arterial vessel compliance. Calcified vessels, loss of arterial distensibility, decreased elastin in vessel walls, more tortuous vessels. Hypertension with an increase in systolic blood pressure. Lungs. Breathing mechanics. Decreased chest wall compliance, loss of elastic recoil. Decreased respiratory muscle mass/strength. Prolonged exhalation phase. Decreased vital capacity. Oxygenation. Increased ventilation/perfusion mismatch. Decreased alveolar surface area. Decreased carbon dioxide diffusion capacity. Decreased PAO2. Decreased cardiac output. Slightly increased PACO2. Breathing control/breathing pattern. Decreased responsiveness of central and peripheral chemoreceptors to hypoxemia and hypercapnia. Increased respiratory rate. Decreased tidal volume. Lung defense mechanisms. Decreased number of cilia. Decreased IgA production and humoral and cellular immunity. Decreased airway clearance. Diminished cough reflex. Increased risk for infection. Sleep and breathing. Decreased respiratory drive. Decreased tone of upper airway muscles. Increased risk of aspiration and respiratory infection. Decreased PAO2. Snoring, obstructive sleep apnea. IgA, immunoglobulin A, PACO2. PACO2, arterial carbon dioxide tension, PAO2. Inspection. Using inspection techniques, perform a head-to-toe observation of the patient for skin and mucous membrane color, general appearance, level of consciousness, adequacy of systemic circulation, breathing patterns, and chest wall movement. Table 41:2. Investigate any abnormalities further during palpation, percussion, and auscultation. Table 41:2. Inspection of cardiopulmonary status. Abnormality. Cause. Eyes. Xanthelasma, yellow lipid lesions on eyelids. Hyperlipidemia. Corneal arcus, whitish opaque ring around junction of cornea and sclera. Abnormal finding in young to middle-age adults with hyperlipidemia, normal finding in older adults with arcus senilis. Pale conjunctivae. Anemia. Cyanotic conjunctivae. Hypoxemia. Petechiae on conjunctivae. Fat embolus or bacterial endocarditis. Mouth and lips. Cyanotic mucous membranes. Decreased oxygenation, hypoxia. Pursed lip breathing. Associated with chronic lung disease. Neck veins. Distension. Associated with right-sided heart failure. Nose. Flaring nares. Air hunger, dyspnea. Chest. Retractions. Increased work of breathing, dyspnea. Asymmetry. Chest wall injury. Skin. Peripheral cyanosis. Vasoconstriction and diminished blood flow. Central cyanosis. Hypoxemia. Decreased skin turgor. Dehydration, normal finding in older adults as a result of decreased skin elasticity. Dependent edema. Associated with right and left-sided heart failure. Periorbital edema. Associated with kidney disease. Fingertips and nail beds. Cyanosis. Decreased cardiac output or hypoxia. Splinter hemorrhages. Bacterial endocarditis. Clubbing. Chronic hypoxemia. Inspection includes observations of the nails for clubbing, see Chapter 31. Clubbed nails often occur in patients with prolonged oxygen deficiency, endocarditis, and congenital heart defects. Observe chest wall movement for retraction, example sinking in of soft tissues of the chest between the intercostal spaces, and use of accessory muscles. Elevation of a patient's clavicles reveals increased work of breathing. Also observe the patient's breathing pattern and assess for paradoxical breathing. The chest wall contracts during inspiration and expands during exhalation, or asynchronous breathing. At rest the normal adult rate is 12 to 20 regular breath/mi and bradypnea is less than 12 breath/min, and tachypnea is greater than 20 breath/min, see Chapter 30. In some conditions, such as metabolic acidosis, the acidic pH stimulates an increase in rate, usually greater than 35 breath/min, and depth of respirations, small respiration, to compensate by decreasing carbon dioxide levels. Apnea is the absence of respirations lasting for 15 seconds or longer. Cheney-Stokes respiration occurs when there is decreased blood flow or injury to the brainstem. This is an abnormal respiratory pattern with periods of apnea followed by periods of deep breathing and then shallow breathing followed by more apnea. McCants and Huther, 2014. Also note the shape of the chest wall. Conditions such as emphysema, advancing age, and COPD cause the chest to assume a rounded barrel shape. Palpation. Palpation of the chest provides assessment data in several areas. It documents the type and amount of thoracic excursion, elicits any areas of tenderness, and helps to identify tactile fremitus, thrills, heaves, and the cardiac point of maximal impulse, PMI. Palpation of the extremities provides data about the peripheral circulation, example the presence and quality of peripheral pulses, skin temperature, color, and capillary refill, see Chapter 31. Palpation of the feet and legs determines the presence or absence of peripheral edema. Patients with alterations in cardiac function such as those with heart failure or hypertension often have pedal or lower extremity edema. Edema is graded from 1+ to 4+ depending on the depth of visible indentation after firm finger pressure, see Chapter 31. Palpate the pulses in the neck and extremities to assess arterial blood flow, see Chapter 31. Use a scale of 0, absent pulse, to 4, full, bounding pulse, to describe what you feel. The normal pulse is 2, and a weak, thready pulse is 1. Percussion. Percussion detects the presence of abnormal fluid or air in the lungs. It also determines diaphragmatic excursion. Auscultation. Auscultation helps identify normal and abnormal heart and lung sounds, see Chapter 31. Auscultation of the cardiovascular system includes assessment for normal S1 and S2 sounds and the presence of abnormal S3 and S4 sounds, gallops, murmurs, or rubs. Identify the location, intensity, pitch, and quality of a murmur. Auscultation also identifies any bruit over the carotid, abdominal aorta, and femoral arteries. Auscultation of lung sounds involves listening for movement of air throughout all lung fields, anterior, posterior, and lateral. Adventitious, or abnormal, breath sounds occur with collapse of a lung segment, fluid in a lung segment, or narrowing or obstruction of an airway. Diagnostic tests. A variety of diagnostic tests monitor cardiopulmonary functioning. Some of these screening tests involve simple blood specimens, X-ray films, or other non-invasive means. One screening mechanism is TB skin testing, box 41-3. This is a simple test and is required for healthcare workers, restaurant employees, students on entry to school, teachers, and other school employees, prisoners and correctional facility employees, and residents of long-term care facilities, CDC, 2014A, 2014B. Box 41-3. Tuberculosis skin testing. Skin testing determines whether a person is infected with Mycobacterium tuberculosis. Tuberculosis, TB, skin testing, TST, is performed by an intradermal injection of 0.1 ml of tuberculin purified protein derivative, PPD, on the inner surface of the forearm, see Chapter 32. The injection produces a pale elevation of the skin, a wheal, 6 to 10 millimeters in diameter. Afterward the injection site is circled, and the patient is instructed not to wash the circle off. Red tuberculin skin tests between 48 to 72 hours after the test. If the site is not red within 72 hours, a patient must have another skin test. Positive results: a palpable, elevated, hardened area around the injection site, caused by edema and inflammation from the antigen-antibody reaction, measured in millimeters. See Chapter 32 for evaluation of positive results by millimeters. People born outside the United States may have had Bacillus-Calmette-Guerin, BCG, vaccine for TB disease, which results in a positive reaction to the TST and may complicate the treatment plan. The positive skin reaction does not indicate that the BCG vaccine provided protection against the disease, CDC, 2014A. Red and flat areas are not positive reactions and are not measured. TST is less reliable in older adults, see box 41-1, and those with an altered immune function such as a human immunodeficiency virus, HIV, positive patient or someone receiving chemotherapy. Diagnostic testing used in the assessment and evaluation of the patient with cardiopulmonary alterations is summarized in tables 41-3 through 41-5. When reviewing results of pulmonary function studies, be aware of expected variations in patients from different cultures. 886 These changes are caused by structural variations in chest wall size, box 41-4. Table 41-3. Cardiopulmonary diagnostic blood studies. Test and normal values. Interpretation. Complete blood count. Normal values for a complete blood count, CBC, vary with age and gender. A CBC determines the number and type of red and white blood cells per cubic millimeter of blood. Cardiac enzymes. Creatine kinase, CK is serial CK with 50% increase between two samples 3 to 6 hours apart, peaking 12 to 24 hours after chest pain or a single CK elevation twofold is diagnostic for an acute myocardial infarction. Male normal, 55 to 170 units/L, female normal, 30 to 135 units/L. Providers use cardiac enzymes to diagnose acute myocardial infarcts. Cardiac troponins. Plasma cardiac troponin I. Value elevates as early as 3 hours after myocardial injury. Value often remains elevated for 7 to 10 days. Plasma cardiac troponin T. Value often remains elevated for 10 to 14 days. Serum electrolytes. Potassium, K+, 3.5 to 5 milliequivalent/L or 3.5 to 5 mol/L. Patients on diuretic therapy are at risk for hypokalemia, low potassium. Patients receiving angiotensin-converting enzyme, ACE, inhibitors are at risk for hyperkalemia, elevated potassium. Cholesterol. Fasting cholesterol less than 200 mg/dl or less than 5.2 mol/L, SI units. Contributing factors include sedentary lifestyle with intake of saturated fatty acids, familial hypercholesterolemia. Low-density lipoproteins, LDLs, bad cholesterol. Very low density lipoproteins, VLDLs, 7 to 32 mg/dl. High LDL cholesterol, hypercholesterolemia, is caused by excessive intake of saturated fatty acids, dietary cholesterol intake, and obesity. Familial hypercholesterolemia and hyperlipidemia, hypothyroidism, nephrotic syndrome, and diabetes mellitus are also contributing factors. VLDLs are predominant carriers of triglycerides and can be converted to LDL by lipoprotein lipase. Levels in excess of 25%-50% indicate increased risk of cardiac disease. High-density lipoproteins, HDLs, good cholesterol. Male, greater than 45 mg/dl, female.
A good way to increase your HDLs as a good cholesterol is exercise.
Female, greater than 55 mg/dl. Factors such as cigarette smoking, obesity, lack of regular exercise, beta-adrenergic blocking agents, genetic disorders of HDL metabolism, hypertriglyceridemia, and type 2 diabetes cause low HDL cholesterol. Triglycerides. Male, 40-160 mg/dl, female, 35-135 mg/dl. Obesity, excessive alcohol intake, diabetes mellitus, beta-adrenergic blocking agents, and familial hypertriglyceridemia cause hypertriglyceridemia. Additional tests. Brain natriuretic peptide. Increased levels may be used to help determine severity of congestive heart failure. C-reactive protein. Test used by clinicians to detect inflammation if there is a high suspicion of tissue injury or infection somewhere in the body. It can also be used to evaluate a patient's risk of developing coronary artery disease and stroke. Data from Pagan et al., Mosby's Diagnostic and Laboratory Test Reference, ed. 12, St. Louis, 2015, Mosby. Table 41-4. Cardiac function diagnostic tests. Test. Significance. Holter monitor. Portable ECG worn by a patient. The test produces a continuous ECG tracing over a period of time. Patients keep a diary of activity, noting when they experience rapid heartbeats or dizziness. Evaluation of the ECG recording along with the diary provides information about the electrical activity of the heart during activities of daily living. ECG exercise stress test. ECG is monitored while a patient walks on a treadmill at a specified speed and duration of time. Test evaluates the cardiac response to physical stress. It is not a valuable tool for evaluation of cardiac response in women because of an increased false positive finding. Thallium stress test. ECG stress test with the addition of thallium-201 injected intravenously. It determines coronary blood flow changes with increased activity. Electrophysiological study, EPS. EPS is an invasive measure of intracardiac electrical pathways. It provides more specific information about difficult-to-treat dysrhythmias and assesses adequacy of antidysrhythmic medication. Echocardiography. This is a non-invasive measure of heart structure and heart wall motion. It graphically demonstrates overall cardiac performance. Scintigraphy. Scintigraphy is radionuclide angiography, used to evaluate cardiac structure, myocardial perfusion, and contractility. Cardiac catheterization and angiography. These are used to visualize cardiac chambers, valves, the great vessels, and coronary arteries. Pressures and volumes within the four chambers of the heart are also measured. ECG, Table 41-5. Ventilation and oxygenation diagnostic studies. Measurement and normal values. Interpretation/purpose. Arterial blood gases. pH 7.35 to 7.45. Provides important information for assessment of patients' respiratory and metabolic acid/base balance and adequacy of oxygenation, see Chapter 42. PC 0235 to 45 mm Hg. HCO3 21 to 28 milliequivalent/L. PO 280 to 100 mm Hg. SO2 saturation 95%-100%. Older adult, 95%. Base excess 0 plus or minus 2 milliequivalent/L. Pulmonary function tests. Basic ventilation studies, pulmonary functions vary by ethnic group. Determines ability of the lungs to efficiently exchange oxygen and carbon dioxide. Used to differentiate pulmonary obstructive from restrictive disease. Peak expiratory flow rate, PEFR. The point of highest flow during maximal expiration, normal in adults, is based on age and body weight. Reflects changes in large airway sizes, an excellent predictor of overall airway resistance in a patient with asthma. Daily measurement for early detection of asthma exacerbations. Bronchoscopy. Normal airways without masses, pus, or foreign bodies. Visual examination of the tracheobronchial tree through a narrow, flexible fiber optic bronchoscope. Performed to obtain fluid, sputum, or biopsy samples, remove mucus plugs or foreign bodies. Lung scan. Normal lung structure without masses. Nuclear scanning test used to identify abnormal masses by size and location. Identification of masses used in planning therapy and treatments. Also used to find a blood clot preventing normal perfusion or ventilation, scan. Thoracentesis. Surgical perforation of chest wall and pleural space with a needle to aspirate fluid for diagnostic or therapeutic purposes or to remove a specimen for biopsy, performed using aseptic technique and local anesthetic. Patient usually sits upright with the anterior thorax supported by pillows or an overbed table. Specimen of pleural fluid obtained for cytological examination. Results may indicate an infection or neoplastic disease. Identification of infection or a type of cancer important in determining a plan of care. Sputum specimens. Nasal aspirate/swabs for respiratory syncytial virus, influenza. Normal, negative. Sputum culture and sensitivity. Obtained to identify a specific microorganism or organism growing in sputum. Identifies drug resistance and sensitivities to determine appropriate antibiotic therapy. Sputum for acid-fast bacillus, AFB. Screens for presence of AFB for detection of tuberculosis by early morning specimens on 3 consecutive days. Sputum for cytology. Obtained to identify lung cancer. Differentiates type of cancer cells, small cell, oat cell, large cell. Invasive diagnostic tests such as a thoracentesis are painful. How painful a diagnostic procedure is depends on the patient's tolerance for pain, see Chapter 44. Reduce the patient's anxiety by explaining the thoracentesis procedure and telling him or her what to expect. Be sure that he or she understands the importance of following instructions such as taking a deep breath and holding it when requested and not coughing during the procedure. Provide appropriate pain management 30 to 60 minutes before the procedure to reduce the perception of pain. After any procedure, monitor the patient for signs of changes in cardiopulmonary functioning such as sudden shortness of breath, pain, oxygen desaturation, and anxiety. Nursing diagnosis. Based upon your assessment, you develop nursing diagnoses for patients with oxygenation alterations by clustering specific defining characteristics. Nursing diagnosis. Based upon your assessment, you develop nursing diagnoses for patients with oxygenation alterations by clustering specific defining characteristics and identifying the related etiology, box 41-5. The defining characteristics for diagnoses related to oxygenation can be similar. For example, both impaired gas exchange and ineffective breathing pattern have the defining characteristics of dyspnea and nasal flaring. A closer review of assessment findings as well as an analysis of the patient's history will help you clarify and select the correct diagnosis. For example, a patient who is a victim of trauma and has rib pain and is showing an increased respiratory rate is more likely to be suffering ineffective breathing pattern. The clustered defining characteristics and related factor will support a problem nursing diagnosis. The clustering of risk factors will support a risk nursing diagnosis. Box 41-5. Nursing diagnostic process. Impaired gas exchange related to decreased lung expansion. Assessment activities. Defining characteristics. Ask patient or family about patient's mood, attentiveness, memory, and activity level. Confusion. Decreased activity. Fatigue. Irritability. Restlessness. Sleepiness. Observe patient's respirations for rate, rhythm, depth. Dyspnea. Nasal flaring. Tachypnea. Use of accessory muscles. Inspect skin and mucous membranes. Diaphoresis. Pallor. Cyanosis. Auscultate chest. Decreased respiratory excursion. Abnormal, distant lung sounds. These nursing diagnosis examples are appropriate for the patient with alterations in oxygenation. Activity intolerance. Decreased cardiac output. Fatigue. Impaired gas exchange. Impaired verbal communication. Ineffective airway clearance. Ineffective breathing pattern. Risk for aspiration. 887. Planning. During planning, use critical thinking skills to synthesize information from multiple sources, figure 41-7. Critical thinking ensures that your plan of care integrates individualized patient needs. Professional standards are especially important to consider when developing a plan of care. These standards often establish scientifically proven guidelines for selecting effective nursing interventions. Figure 41-7 Critical Thinking Model for Oxygenation Planning. Goals and Outcomes. Develop an individualized plan of care for each nursing diagnosis, see the nursing care plan. Together with your patient, set realistic expectations, goals, and measurable outcomes of care. Oxygenation require a nursing care plan directed toward meeting actual or potential oxygenation needs. Allow patients to collaborate in setting relevant goals of care. Develop individual outcomes based on patient-centered goals. For example, for the goal of maintaining a patent airway, select specific expected outcomes for the patient, such as the following. Patient's lungs are clear to auscultation. Patient achieves bilateral lung expansion. 888. Patient coughs productively. pulse oximetry, SpO2, is maintained or improved. Often a patient with cardiopulmonary disease has multiple nursing diagnoses, figure 41-8. In this case, identify when goals or outcomes apply to more than one diagnosis. The presence of multiple diagnoses also makes priority setting a critical activity. Figure 41-8 concept map for Mr. Edwards. Setting priorities. A patient's level of health, age, lifestyle, and environmental risks affect the level of tissue oxygenation. Patients with severe impairments in oxygenation frequently require nursing interventions in multiple areas. Consider which goal is the most important to achieve while the patient is in the hospital or primary care setting. For example, in an acute care setting, maintaining a patent airway has a higher priority than improving the patient's exercise tolerance. The need for a patent airway is immediate, and, as the patient's level of oxygen improves, activity tolerance increases. In a second example, when caring for a patient who has an abdominal incision, pain control is a priority. In this situation, controlling the patient's pain facilitates coughing and deep breathing and activity. However, in a community-based or primary care setting, priorities often focus on smoking cessation, exercise, and/or diet modifications. Both you and the patient need to focus on the same goal and expected outcomes. In addition to individualizing each goal, be sure that the goals are realistic, have a reasonable time frame, and are attainable for the patient. In addition, be sure to respect the patient's preferences for his or her degree of active engagement in the care process. Some will choose to be very active and desire to make day-to-day decisions. Others may choose to assume a more passive role, preferring you to choose a course of action while keeping them informed. Teamwork and collaboration. The time spent with a patient in any setting is limited. Therefore, collaborate with family members, colleagues, and other healthcare specialists to achieve the established goals and expected outcomes. Some patients need to improve their exercise and activity tolerance. For other patients, continuing care involves participating in a community-based cardiopulmonary rehabilitation program. Finally, some patients need home physical therapy. Collaboration with physical therapists, nutritionists, and community-based nurses is valuable for patients with heart failure or chronic lung conditions. These professionals work with patients and use resources in the community to assist them in attaining and maintaining the highest possible level of wellness. In addition, professionals identify community resources and support systems for both the patient and family in preventing and managing symptoms related to cardiopulmonary diseases. Communicating among everyone on the patient's healthcare team and recognizing everyone's contributions in achieving the healthcare goals for the patient are imperative. Implementation. There are interventions for promoting and maintaining adequate oxygenation across the continuum of care. As a nurse, you will be responsible for independent interventions such as positioning, coughing techniques, and health education for disease prevention. In addition, you will provide physician-initiated interventions such as oxygen therapy, lung inflation techniques, and chest physiotherapy. Health promotion. Maintaining a patient's optimal level of health is important in reducing the number and/or severity of 890 respiratory symptoms. Prevention of respiratory infections is foremost in maintaining optimal health. Providing cardiopulmonary-related health information, Box 41-6, is an important nursing responsibility. Box 41-6. Patient teaching. Prevention of recurrent respiratory infections. Objective. The patient will be able to verbalize the methods to reduce the risk factors for recurring respiratory infections. Teaching strategies. Assess the patient's health literacy, educational background, reading level, and cultural preferences to determine appropriate educational approaches. Communicate with patient and family to identify collaborative goals for reducing risk factors. Explain the link between smoking and increased risk for respiratory infections, CDC, 2014c. Refer to smoking cessation programs and discuss appropriate medication to support smoking cessation from the primary health provider, ACS, 2014b. If a patient does not smoke, teach the importance of avoiding second-hand smoke and areas of high air pollution. Instruct patient and family about appropriate hand hygiene techniques to reduce transmission of microorganisms. Explain to patient and family why annual influenza vaccines and appropriate pneumonia vaccines are needed, CDC, 2014c, e.g. Instruct patient and family about signs and symptoms of respiratory infection that should be reported to healthcare providers, such as increased coughing, shortness of breath, change of color of sputum, fever, and fatigue. Evaluation. Ask patient to state benefits of smoking cessation and the risks for second-hand smoke. Ask patient about plans for flu and pneumonia vaccines. Ask patient to describe in simple terms the symptoms of respiratory infection and when to call the healthcare provider. The health information that your patients and their families bring to the situation varies. Some patients have a lot of exposure to healthcare information and understand their treatment plans. Other families might have a lot of exposure to healthcare information but are unable to understand and follow treatment plans. Last, you might encounter families who are experiencing their first exposure to healthcare information and are very unsure of their interpretation of the information. When providing health information, Be sure that the patient's health literacy levels are assessed and addressed through individualized patient education sessions. See Chapter 25. Vaccinations. Annual flu vaccines are recommended for all people 6 months and older. CDC, 2014a. Patients with chronic illnesses, heart, lung, kidney, or immunocompromised, infants, older adults, and pregnant women can get very sick, thus they should be immunized. CDC, 2014g. Close contacts of infants under 6 months should also be immunized. Seasonal flu vaccine protects against influenza viruses that research indicates will be the most common during that year. The vaccine is also recommended for people in close or frequent contact with anyone in the high-risk groups. It is effective in reducing the severity of illness and the risk of serious complications and death. Researchers do not fully understand the value of vaccination in immune-compromised patients. HIV-positive patients receive the flu vaccine, however, they often require a second vaccine to gain protection. It is important to assess patients' allergies and any allergic response 891 to vaccines or any components. People with a known hypersensitivity to eggs or other components of the vaccine should consult their physician before being vaccinated. There is a flu vaccine made without egg proteins that is approved for adults 18 years of age and older, Lee, 2013. Adults with an acute febrile illness should schedule the vaccination after they have recovered. The vaccines are formulated annually based on worldwide surveillance data. The live, attenuated nasal spray vaccine is given to people from 2 through 49 years of age if they are not pregnant or do not have certain long-term health problems such as asthma, heart, lung, or kidney disease, diabetes, or anemia. The inactivated flu vaccine should be given to these individuals and those 50 and older, CDC, 2014a. Pneumococcal vaccine, PCV13, is routinely given to infants in a series of 4 doses and is recommended for patients at increased risk of developing pneumonia. This includes all adults over 65 years of age, those with chronic illnesses or who are immunocompromised, such as HIV/AIDS, any adult who smokes or has asthma, and those living in special environments such as nursing homes or long-term care facilities, CDC, 2013c. Healthy lifestyle. Identification and elimination of risk factors for cardiopulmonary disease are important parts of primary care. Encourage patients to eat a healthy low-fat, high-fiber diet, monitor their cholesterol, triglyceride, high-density lipoprotein, HDL, and low-density lipoprotein, LDL, levels, reduce stress, exercise, and maintain a body weight in proportion to their height. Eliminating cigarettes and other tobacco, reducing exposure to pollutants, monitoring air quality, and adequately hydrating are additional healthy behaviors. Encourage patients to examine their habits and make appropriate changes. Patients with cardiopulmonary alterations need to minimize their risk for infection, especially during the winter months. See box 41-6. Exercise is a key factor in promoting and maintaining a healthy heart and lungs. Encourage patients to exercise at least 3 to 4 times a week for 30 to 60 minutes. Aerobic exercise is necessary to improve lung and heart function and strengthen muscles. Walking is an efficient way to achieve a good aerobic workout. Many shopping malls have programs allowing people to walk in the enclosed mall before the shops open. During the hot summer months, teach patients to limit activities to early in the day or late in the evening, when temperatures are lower. Teach them how to maintain adequate hydration and sodium intake, especially if they are taking diuretics. Patients with known cardiac disease and those with multiple risk factors are cautioned to avoid exertion in cold weather. Shoveling snow is especially risky and often precipitates a cardiac event. Other activities such as hanging holiday lights and decorations in the extreme cold can precipitate chest pain and bronchospasm. Environmental pollutants. Avoiding exposure to second-hand smoke is essential to maintaining optimal cardiopulmonary function. Most businesses and restaurants now ban smoking or have separate areas designated as smoking areas. If patients are exposed to second-hand smoke in their home environments, counseling and support for all family members are necessary. Family members need to support the smoker in successful smoking cessation. Consider if a patient is exposed to chemicals and pollutants in the work environment. Farmers, painters, carpenters, and others benefit from the use of particulate filter masks to reduce the inhalation of particles. Acute care. Box 41-5. Nursing. Acute care. Patients with acute pulmonary illnesses require nursing interventions directed toward halting the pathological process, example respiratory tract infection, shortening the duration and severity of an illness, example hospitalization with pneumonia, and preventing complications from the illness or treatments, example hospital-acquired infection resulting from invasive procedures. Dyspnea management. Dyspnea is difficult to treat. Healthcare providers individualize treatments for each patient and usually implement more than one therapy. Treatment of the underlying process causing dyspnea is then followed with other therapies, example pharmacological measures, oxygen therapy, physical techniques, and psychosocial techniques. Pharmacological agents include bronchodilators, inhaled steroids, mucolytics, and low-dose anti-anxiety medications. Oxygen therapy reduces dyspnea associated with exercise and hypoxemia. Physical techniques such as cardiopulmonary reconditioning, example exercise, breathing techniques, and cough control, relaxation techniques, biofeedback, and meditation are also beneficial. Airway maintenance. The airway is patent when the trachea, bronchi, and large airways are free from obstructions. Airway maintenance requires adequate hydration to prevent thick, tenacious secretions. Proper coughing techniques remove secretions and keep the airway open. A variety of interventions such as suctioning, chest physiotherapy, and nebulizer therapy assist patients in managing alterations in airway clearance. Mobilization of pulmonary secretions. The ability of a patient to mobilize pulmonary secretions makes the difference between a short-term illness and a long recovery involving complications. Nursing interventions promoting removal of pulmonary secretions assist in aid 92 achieving and maintaining a clear airway and help to promote lung expansion and gas exchange. Hydration. Maintenance of adequate systemic hydration keeps mucociliary clearance normal. In patients with adequate hydration, pulmonary secretions are thin, white, watery, and easily removable with minimal coughing. Excessive coughing to clear thick, tenacious secretions is fatiguing and energy depleting. The best way to maintain thin secretions is to provide a fluid intake of 1,500 to 2,500 ml/day unless contraindicated by cardiac or renal status. The color, consistency, and ease of mucus expectoration determine adequacy of hydration. Humidification. Humidification is the process of adding water to gas. Temperature is the most important factor affecting the amount of water vapor a gas can hold. Relative humidity is the percentage of water in the gas. Air or oxygen with a high relative humidity keeps the airways moist and loosens and mobilizes pulmonary secretions. Humidification is necessary for patients receiving oxygen therapy at greater than 4L/min, Czech agency protocol. It might be necessary to add humidification at lower oxygen concentrations if the environment is dry and arid. Bubbling oxygen through water adds humidity to the oxygen delivered to the upper airways, see Skill 41-4. An oxygen hood is used for infants, and a humidity tent is used for children with illnesses such as croup and tracheitis to liquefy secretions and help reduce fever, Hockenberry and Wilson, 2015. The nebulizer at the top of the humidity tent remains filled with water to prevent non-humidified air or oxygen from entering the tent. Air in the humidity tent sometimes becomes cool and falls below 20 degrees Celsius 68 degrees Fahrenheit, causing the child to become chilled. Children in humidity tents require frequent changes of clothing and bed linen to remain warm and dry. Nebulization. Nebulization adds moisture or medications to inspired air by mixing particles of varying sizes with the air. Aerosolization suspends the maximum number of water drops or particles of the desired size in inspired air. The moisture added through nebulization improves clearance of pulmonary secretions. Nebulization delivers bronchodilators and mucolytic agents. When the thin layer of fluid supporting the mucus layer over the cilia dries, the cilia are damaged and unable to adequately clear the airway. Humidification through nebulization enhances mucociliary clearance, the natural mechanism of the body for removing mucus and cellular debris from the respiratory tract. Coughing and deep breathing techniques. Coughing is effective for maintaining a patent airway. Directed coughing is a deliberate maneuver that is effective when spontaneous coughing is not adequate. AARC, 1993, Borga et al., 2014. Directed coughing permits a patient to remove secretions from both the upper and lower airways. The normal series of events in the cough mechanism are deep inhalation, closure of the glottis, active contraction of the expiratory muscles, and glottis opening. Deep inhalation increases the lung volume and airway diameter, allowing the air to pass through partially obstructing mucus plugs or other foreign matter. Contraction of the expiratory muscles against the closed glottis causes a high intrathoracic pressure to develop. When the glottis opens, a large flow of air is expelled at a high speed, providing momentum for mucus to move to the upper airways where the patient can expectorate or swallow it. Diaphragmatic breathing/belly breathing is a technique that encourages deep breathing to increase air to the lower lungs. The diaphragm descends, belly moves out, when breathing in and ascends, belly sinks in, when breathing out, CFF, 2012. Deep breathing also opens the pores of cone between alveoli to allow sharing of oxygen between alveoli. This is especially important if the airway of the alveoli is plugged with mucus. The neighboring alveoli can share the air distribution through the pores of cone. Evaluate the effectiveness of coughing by sputum expectoration, the patient's report of swallowed sputum, or clearing of adventitious sounds by auscultation. Encourage patients with chronic pulmonary diseases, upper respiratory tract infections, and lower respiratory tract infections to deep breathe and cough at least every 2 hours while awake. Encourage patients with a large amount of sputum to cough every hour while awake and then awaken them at night to cough every 2 to 3 hours. This is necessary until the acute phase of mucus production has ended. After surgery, it is recommended that patients perform directed cough every 2 to 4 hours while awake to prevent accumulation of secretions. Offer postoperative patient support devices, folded blanket, pillow, or palmed hands, to splint an abdominal or thoracic incision to minimize pain during directed coughing. Cough is a source of droplet transmission of pulmonary pathogens, thus the healthcare provider should follow standard precautions. Coughing techniques include deep breathing and coughing for the postoperative patient, cascade, huff, and quad coughing, Borga et al., 2014. With the cascade cough, the patient takes a slow, deep breath and holds it for 2 seconds while contracting expiratory muscles. Then he or she opens the mouth and performs a series of coughs throughout exhalation, thereby coughing at progressively lowered lung volumes. This technique promotes airway clearance and a patent airway in patients with large volumes of sputum. The huff cough stimulates a natural cough reflex and is generally effective only for clearing central airways. While exhaling, the patient opens the glottis by saying the word huff. With practice, he or she inhales more air and is able to progress to the cascade cough. The quad cough technique is for patients without abdominal muscle control, such as those with spinal cord injuries. While the patient breathes out with a maximal expiratory effort, the patient or nurse pushes inward and upward on the abdominal muscles toward the diaphragm, causing the cough. Chest physiotherapy. Cystic fibrosis exemplar. Chest physiotherapy, CPT, is a group of therapies for mobilizing pulmonary secretions. These therapies include postural drainage, chest percussion, and vibration. CPT is followed by productive coughing or suctioning of a patient who has a decreased ability to cough. It is recommended for patients who produce greater than 30 ml of sputum per day or have evidence of atelectasis on chest X-ray examination, AARC, 2012. The procedure is safe for infants and young children, however, at times conditions and diseases unique to children contraindicate it. CPT is for a select group of patients. Box 41-7 describes the guidelines to determine if CPT is indicated. Box 41-7. Guidelines for chest physiotherapy. Nursing and respiratory therapy collaborate with the healthcare provider to determine if chest physiotherapy, CPT, is best for the patient. The following guidelines help in physical assessment and subsequent decision making. Know a patient's normal range of vital signs. The degree of change is related to the level of hypoxia, overall cardiopulmonary status, and tolerance to activity. Conditions requiring CPT such as atelectasis and complicated pneumonia affect vital signs. Conduct a respiratory assessment to confirm need for CPT, including sputum production, effectiveness of cough, history of pulmonary problems successfully relieved with CPT, abnormal lung sounds, documented conditions such as atelectasis, complicated pneumonia, and changes in oxygenation status, AARC, 2012. Know the patient's medications. Certain medications, particularly diuretics and antihypertensives, cause fluid and hemodynamic changes. These decrease a patient's tolerance to positional changes and postural drainage. Long-term steroid use increases a patient's risk of pathological rib fractures and often contraindicates vibration. Know the patient's medical history. Certain conditions such as increased intracranial pressure, spinal cord injuries, and abdominal aneurysm resection contraindicate the positional changes of postural drainage. Thoracic trauma or surgery contraindicates percussion and vibration. Know the patient's level of cognitive function. Participation in controlled coughing techniques requires him or her to follow instructions. Congenital or acquired cognitive limitations alter a patient's ability to learn and participate in these techniques. Be aware of the patient's exercise tolerance. CPT maneuvers are fatiguing. Postural drainage is a component of pulmonary hygiene. It consists of drainage, positioning, and turning and is sometimes accompanied by chest percussion and vibration, CFF, 2012. It improves secretion clearance and oxygenation. Positioning involves draining affected lung segments, table 41-6, and helps to drain secretions from those segments of the lungs and bronchi into the trachea. Some patients do not require postural drainage of all lung segments, and clinical assessment is crucial in identifying specific lung segments requiring it. For example, patients with left lower lobe atelectasis require postural drainage of only the affected region, whereas a child with cystic fibrosis often requires postural drainage of all lung segments. Table 41-6. Positions for postural drainage. Lung segment. Position of patient. Lung segment. Position of patient. Adult. Bilateral. High Fowler's. Left lower lobe lateral segment. Right side lying in Trendelenburg's position. Apical segments. Sitting on side of bed. Right lower lobe lateral segment. Left side lying in Trendelenburg's position. Right upper lobe anterior segment. Supine with head elevated. Right lower lobe posterior segment. Prone with right side of chest elevated in Trendelenburg's position. Left upper lobe anterior segment. Supine with head elevated. Right middle lobe posterior segment. Prone with thorax and abdomen elevated. Right upper lobe posterior segment. Side lying with right side of chest elevated on pillows. Both lower lobes anterior segments. Supine in Trendelenburg's position. Left upper lobe posterior segment. Side lying with left side of chest elevated on pillows. Both lower lobes posterior segments. Prone in Trendelenburg's position. Right middle lobe anterior segment. 3/4 supine position with dependent lung in Trendelenburg's position. Child. Bilateral apical segments. Sitting on nurse's lap, leaning slightly forward flexed over pillow. Bilateral lobes anterior segments. Lying supine on nurse's lap, back supported with pillow. Bilateral middle anterior segments. Sitting on nurse's lap, leaning against nurse. Chest percussion involves rhythmically clapping on the chest wall over the area being drained to force secretions into larger airways for expectoration, AARC, 2012. It is commonly performed by respiratory therapists in larger healthcare settings. Position your hand so the fingers and thumb touch and the hands are cupped. The cupping makes the hand conform to the chest wall while trapping a cushion of air to soften the intensity of the clapping. The procedure should produce a hollow sound and should not be painful, CFF, 2012. Perform chest percussion by vigorously striking the chest wall 894 alternately with cupped hands, figure 41-9. Perform percussion over a single layer of clothing, not over buttons, snaps, or zippers. The single layer of clothing prevents slapping the patient's skin. Thicker or multiple layers of material dampen the vibrations. Figure 41-9 chest wall percussion, alternating hand clapping against patient's chest wall. Percussion is contraindicated in patients with bleeding disorders, osteoporosis, or fractured ribs. Avoid percussion over burns, open wounds, or skin infections of the thorax. Take caution to percuss the lung fields under the ribs and not over the spine, breastbone, stomach, or lower back or trauma can occur to the spleen, liver, or kidneys, CFF, 2012. Vibration is a gentle, shaking pressure applied to the chest wall to shake secretions into larger airways. Place a flattened hand or two hands firmly on the chest wall over the appropriate segment and press the top and bottom hand into each other to vibrate. Tense the muscles of the arm to provide a shaking motion. Have the patient exhale as slowly as possible during the vibration. This technique increases the velocity and turbulence of exhaled air, facilitating secretion removal. Vibration increases the exhalation of trapped air, shakes mucus loose, and induces a cough, CFF, 2012. A patient may also be instructed to use a vest airway clearance system. The vest airway clearance systems use high-frequency chest wall oscillation, HFQO, or compression to assist removal of secretions from the lungs. This vest is beneficial for patients with neuromuscular diseases and for patients with chronic lung diseases, such as cystic fibrosis. The goals of oscillating vests are, 1. To clear the airways of excessive secretions to reduce the work of breathing, and 2. To improve a patient's ability to cough up secretions, Morrison and Agnew, 2014. The vest fits over the patient's clothing and makes it possible for patients to continue airway clearance therapies in the home and school environments when necessary. Suctioning techniques. Suctioning is necessary when patients are unable to clear respiratory secretions from the airways by coughing or other less invasive procedures. Suctioning techniques include oropharyngeal and nasopharyngeal suctioning, orotracheal and nasotracheal suctioning, and suctioning an artificial airway. 895. In most cases use sterile technique for suctioning because the oropharynx and trachea are considered sterile. The mouth is considered clean, therefore you suction oral secretions after suctioning the oropharynx and trachea. In the home setting, use a clean versus sterile technique because the patient is not exposed to pathogens common to healthcare settings. Teach patients appropriate measures for disinfecting equipment, AARC, 2004, 2010A. Each type of suctioning requires the use of a round-tipped, flexible catheter with holes on the sides and end of the catheter. When suctioning, you apply negative pressures, 100 to 150 mm Hg for adults, during withdrawal of the catheter, never on insertion, AARC, 2010A. Patient assessment determines the frequency of suctioning. It is indicated when ronchi, gurgling breath sounds, and diminished breath sounds are audible on auscultation or visible secretions are present after other methods to remove airway secretions have failed. You may also use suctioning to obtain a sputum specimen for culture or cytology if the patient is not able to cough productively. Too frequent suctioning puts patients at risk for development of hypoxemia, hypotension, arrhythmias, and possible trauma to the mucosa of the lungs, AARC, 2010A, Lynn McHale, 2011. Oropharyngeal and nasopharyngeal suctioning. Oropharyngeal or nasopharyngeal suctioning is used when a patient is able to cough effectively but unable to clear secretions by expectorating. Apply suction after a patient has coughed, see Skill 41-1 on pages 907 to 914. Once the pulmonary secretions decrease and a patient is less fatigued, he or she is then able to expectorate or swallow the mucus, and suctioning is no longer necessary. Orotracheal and nasotracheal suctioning. Orotracheal or nasotracheal suctioning is necessary when a patient with pulmonary secretions is unable to manage secretions by coughing and does not have an artificial airway present, see Skill 41-1. You pass a sterile catheter through the mouth or nose into the trachea. The nose is the preferred route because stimulation of the gag reflex is minimal. The procedure is similar to nasopharyngeal suctioning, but you advance the catheter tip farther into the patient's trachea. The entire procedure from catheter passage to its removal is done quickly, lasting no longer than 10 seconds, AARC, 2010A. Allow the patient to rest between passes of the catheter. If the patient develops respiratory distress, stop suctioning unless the collection of secretions is causing distress. If the patient is using supplemental oxygen, replace the oxygen cannula or mask during rest periods. Tracheal suctioning. Perform tracheal suctioning through an artificial airway such as an endotracheal, ET, or tracheostomy tube. The size of a catheter should be as small as possible but large enough to remove secretions. Recommendation is about half the internal diameter of the ET tube, AARC, 2010A. Never apply suction pressure while inserting the catheter to avoid traumatizing the lung mucosa. Once you insert a catheter the necessary distance, maintain suction pressure between 120 and 150 mm Hg, AARC, 2010A, as you withdraw. Apply suction intermittently only while withdrawing the catheter. Rotating the catheter enhances removal of secretions that have adhered to the sides of the airway. The practice of normal saline installation, NSI, into artificial airways to improve secretion removal may be harmful and is not recommended. Clinical studies comparing the results of suctioning following NSI with standard suctioning have not shown any clinical or significant results, AARC, 2010A. The two current methods of suctioning are the open and closed methods. Open suctioning involves using a new sterile catheter for each suction session, AARC, 2010A. Wear sterile gloves and follow standard precautions during the suction procedure. Closed suctioning involves using a reusable sterile suction catheter that is encased in a plastic sheath to protect it between suction sessions, figure 41-10. Closed suctioning is most often used on patients who require invasive mechanical ventilation to support their respiratory efforts because it permits continuous delivery of oxygen while suction is performed and reduces the risk of oxygen desaturation. Although sterile gloves are not used in this procedure, non-sterile gloves are recommended to prevent contact with splashes from body fluids, see Skill 41-1. Figure 41-10 Ballard tracheal care, closed suction catheter. Artificial airways. An artificial airway is for a patient with a decreased level of consciousness or airway obstruction and aids in removal of tracheobronchial secretions. The presence of an artificial airway places a patient at high risk for infection and airway injury. Use clean technique for oral airways, but use sterile technique in caring for and maintaining endotracheal and tracheal airways to prevent healthcare associated infections, HIEs. Artificial airways need to stay in the correct position to prevent airway damage. See Skill 41-2 on pages 915 to 922. Oral airway. The oral airway, the simplest type of artificial airway, prevents obstruction of the trachea by displacement of the tongue into the oropharynx, figure 41-11. The oral airway extends from the teeth to the oropharynx, maintaining the tongue in the normal position. Use the correct size airway. Determine the proper oral airway size by measuring the distance from the corner of the mouth to the angle of the jaw just below the ear. The length is equal to the distance from the flange of the airway to the tip. If the airway is too small, the tongue does not stay in the anterior portion of the mouth. If the airway is too large, it forces the tongue toward the epiglottis and obstructs the airway. Figure 41-11 Artificial oral airways. Insert the airway upside down, then turn to the curve of the airway toward the cheek and place it over the tongue. When the airway is in the oropharynx, turn it so the opening points downward. Correctly placed, the airway moves the tongue forward away from the oropharynx, and the flange, example the flat portion of the airway, rests against 896 the patient's teeth. Incorrect insertion merely forces the tongue back into the oropharynx. Endotracheal and tracheal airway. An endotracheal, ET, tube is a short-term artificial airway to administer invasive mechanical ventilation, relieve upper airway obstruction, protect against aspiration, or clear secretions. A physician or specially trained clinician inserts the ET tube. The tube is passed through the patient's mouth, past the pharynx, and into the trachea, figure 41-12. It is generally removed within 14 days, however, it is sometimes used for a longer period of time if the patient is still showing progress toward weaning from invasive mechanical ventilation and extubation. Figure 41-12 Endotracheal tube inserted into trachea. Cuff inflated to maintain position. Copyright 2015 Medtronic. All rights reserved. Used with the permission of Medtronic. If a patient requires long-term assistance from an artificial airway, a tracheostomy is considered. A surgical incision is made into the inferior border of the cricoid cartilage of the trachea, and a short tracheostomy tube is inserted. Most tracheostomies have a small plastic inner tube that fits inside a larger one, the inner cannula. The most common complication of a tracheostomy tube is partial or total airway obstruction caused by buildup of respiratory secretions. If this occurs, the inner tube can be removed and cleaned or replaced with a temporary spare inner tube that should be kept at the patient's bedside. Keep tracheal dilators at the bedside to have available for emergency tube replacement or reinsertion. Humidification from air humidifiers or humidified oxygen tracheostomy collars can help prevent drying of secretions that cause occlusion. Tracheostomy suctioning should be done as often as necessary to clear secretions. The majority of patients with a tracheostomy tube cannot speak because the tube is inserted below the vocal cords. It is important to use written or nonverbal communication, lip reading, Strategies to help patients communicate. Be sure to assess patients for anxiety caused by the inability to speak. Care and cleaning of the tracheostomy tube is discussed in Skill 41-2. Maintenance and promotion of lung expansion. Nursing interventions to maintain or promote lung expansion include non-invasive techniques such as ambulation, positioning, incentive spirometry, and non-invasive ventilation. Invasive medical interventions such as chest tube insertion and management assist in restoring lung expansion. Ambulation. Immobility is a major factor in developing atelectasis, ventilator-associated pneumonia, VAP, and functional limitations. The research has shown that, after 1 week of bed rest, muscle strength declines by American Samoa much as 20%, which results in an increased oxygen demand, weakened respiratory muscles, and a decline of functional status. Early ambulation studies indicate that the therapeutic benefits of activity include an increase in general strength and lung expansion. Even the patient who requires invasive mechanical ventilation benefits by an early mobility program. Such mobility programs should include input from both respiratory and physical therapists in the treatment plan. Atkins and Kotz, 2014. Progressive mobilization from dangling the legs to standing and then walking is safe for intubated patients. Atkins and Kotz, 2014. Positioning. The healthy, completely mobile person maintains adequate ventilation and oxygenation by frequent position changes during daily activities. However, when a person's illness or injury restricts mobility, the risk for respiratory impairment is increased. Frequent changes of position are simple and cost-effective methods for reducing stasis of pulmonary secretions and decreased chest wall expansion, both of which increase the risk of pneumonia. Research has shown that turning critically ill patients every 2 hours is not often enough to prevent pneumonia. Raw-NETAL, 2008.
That's crazy.
The 45-degree semi-Fowler's is the most effective position to promote lung expansion and reduce pressure from the abdomen on the diaphragm. When a patient is in this position, be sure that he or she does not slide down in bed, which can reduce lung expansion. Sliding also increases the risk of pressure ulcers. A patient with unilateral lung disease such as pneumothorax, atelectasis, or pneumonia of one lung should be positioned in a manner to promote perfusion of the healthy lung and improve oxygenation. In most cases, position the patient with the good lung down. Raw-NETAL, 2008. In the presence of pulmonary abscess or hemorrhage, position the patient with the affected lung down to prevent drainage toward the healthy lung. For bilateral lung disease, the best position depends on the severity of the disease. Incentive spirometry. Incentive spirometry encourages voluntary deep breathing by providing visual feedback to patients about inspiratory volume. It promotes deep breathing and prevents or treats atelectasis in the postoperative patient. There is solid evidence to support the use of lung expansion with incentive spirometry in preventing postoperative pulmonary complications following surgery. AARC, 2011, Cassidy et al., 2013. Flow-oriented incentive spirometers consist of one or more plastic chambers that contain freely moving colored balls. A patient inhales slowly and with an even flow to elevate the balls and keep them floating as long as possible to ensure a maximally sustained inhalation. Volume-oriented incentive spirometry devices have a bellows that is raised to a predetermined volume by an inhaled breath. Figure 41-13. An achievement light or counter is used to provide feedback. Some devices are constructed so the light does not turn on unless the bellows is held at a minimum desired volume for a specified period to enhance lung expansion. See Chapter 50. Figure 41-13. Volume-oriented incentive spirometer. Incentive spirometry encourages patients to use visual feedback to maximally inflate their lungs and sustain that inflation. AARC, 2011. A postoperative inspiratory capacity 1/2 to 3/4 of the preoperative volume is acceptable because of postoperative pain. The AARC guidelines, 2011, recommend 5 to 10 breaths per session every hour while awake. Administration of pain medications before incentive spirometry helps a patient achieve deep breathing by reducing pain and splinting. Invasive mechanical ventilation. Invasive mechanical ventilation, also referred to as positive pressure ventilation, is a life-saving technique used with artificial airways, ET or tracheostomy, for various physiological and clinical indications. Physiological indications for invasive mechanical ventilation include supporting cardiopulmonary gas exchange, alveolar ventilation and arterial oxygenation, increasing lung volume, and reducing the work of breathing. Erden et al., 2014. 897 clinical indications for invasive mechanical ventilation include reversing hypoxia and acute respiratory acidosis, relieving respiratory distress, preventing or reversing atelectasis and respiratory muscle fatigue, allowing for sedation and/or other neuromuscular blockade, decreasing oxygen consumption, reducing intracranial pressure and stabilizing the chest wall. Erden et al., 2014. It can be used to either fully or partially replace spontaneous breathing depending on the need of the patient. Invasive mechanical ventilation also redistributes blood flow from working respiratory muscles to other vital organs. Following an inspiratory trigger, invasive mechanical ventilation forces a preset mixture of air, oxygen and other gases, into the central airways and then flows into the alveoli, causing the intraalveolar pressure to increase as the lungs inflate. A termination signal triggers the ventilator to cease forcing air into the central airways, causing the central airway pressure to decrease. Expiration then follows passively, the air flowing from the higher alveoli pressure to the lower pressure of the central airways. There are a variety of ventilator modes. The choice depends on the patient's situation and goals of treatment. Many of the modes are used in conjunction with each other. There are numerous brands of ventilators and they vary in their ability to perform certain functions. Not all modes are available on all ventilators. The most commonly used modes include assist control, AC, synchronized intermittent mandatory ventilation, SIMV, and pressure support ventilation, PSV. Assist control delivers a set tidal volume, VT, with each breath, regardless if the breath was triggered by the patient or the ventilator. Synchronized intermittent mandatory ventilation, like AC, delivers a minimum number of fully assisted breaths per minute that are synchronized with the patient's respiratory effort. Any breaths taken between volume cycled breaths are not assisted. The volume of these breaths is determined by the patient's strength, effort, and lung mechanics. Pressure support mode is often combined with SIMV mode. Inspiratory pressure is added to spontaneous breaths to overcome the resistance of the endotracheal tube or to help increase the volume of the patient's spontaneous breaths. Although invasive mechanical ventilation is often life-saving, it is not without complications. Some complications are preventable and others can be minimized. Physiological complications associated with invasive mechanical ventilation include belotrauma, cardiovascular compromise, gastrointestinal disturbances, and ventilator-assisted pneumonia, Erden et al., 2014. Belotrauma occurs as a result of alveolar overdistension secondary to the mechanical ventilation. Cardiovascular compromise occurs as a result of the increased intrathoracic pressure. It is caused by positive pressure ventilation that decreases venous return to the right side of the heart, decreasing preload and resulting in a decreased cardiac output. Gastrointestinal, GI, disturbances commonly occur. They are related to gastric distension, vomiting related to pharyngeal stimulation from the artificial airway, constipation, and hypomotility, due to immobility and the administration of analgesics, sedatives, and paralytic agents. Pneumonia exemplar. Ventilator-associated pneumonia, VAP, is a significant potential complication because the artificial airway tube bypasses many of the lung's normal defense mechanisms. Ventilator-associated pneumonia, VAP, is a healthcare, acquired infection, that develops in a person requiring invasive mechanical ventilation, via endotracheal intubation or tracheotomy tube, for at least 48 hours, Ch41 et al., 2013. It is a potentially serious complication in patients who are already critically ill. VAP mortality rates ranges from 20% to 50% among ventilated patients and is estimated to add an additional $40,000 to the cost of a hospital admission, Monaco et al., 2014, Box 41-8. Hospitals are not reimbursed for costs associated with VAP. Non-invasive ventilation. Non-invasive positive pressure ventilation, NPPV, is used to prevent using invasive artificial airways, ET tube or tracheostomy, in patients with acute respiratory failure, cardiogenic pulmonary edema, or exacerbation of COPD. It has also been used following extubation of an ET tube, Logo et al., 2014. The purpose of NPPV is to maintain a positive airway pressure and improve alveolar ventilation. This prevents or treats atelectasis by inflating the alveoli, reducing pulmonary edema by forcing fluid out of the lungs back into circulation, and improving oxygenation in those with sleep apnea. Ventilatory support is achieved using a variety of modes, including continuous positive airway pressure, CPAP, and bilevel positive airway pressure, BiPAP. CPAP treats patients with obstructive sleep apnea, patients with heart failure, and preterm infants with underdeveloped lungs. In obstructive sleep apnea, airways collapse, causing shallow or absent breathing. Any air moving past the obstruction results in loud snoring. An overnight sleep study may be needed to determine the correct settings for a CPAP machine, see Chapter 43. Equipment includes a mask, figure 41-14, that fits over the nose or both nose and mouth and a CPAP machine that delivers air to the mask, National Heart, Lung and Blood Institute, 2011. The smallest mask with the proper fit is the most effective. Because straps hold the mask in place, it is important to assess for excess pressure on the patient's face or nose that could cause skin breakdown or necrosis. The mask should have enough slack to allow 1 to 2 fingers between the straps and the face, Suhu et al., 2014. However, it must also be tight enough to form a tight seal on the face so the air does not escape. With higher pressures, escape of some air may be avoidable. Figure 41-14 CPAP mask. The most common mode of support is BiPAP that provides both inspiratory positive airway pressure, IPAP, and expiratory airway pressure, EPAP, also known as positive and expiratory pressure, PEEP. The difference between these two pressures indicates the amount of pressure support a patient needs, Suhu et al., 2014. During inhalation, the positive pressure increases the patient's tidal volume and alveolar ventilation. The pressure support decreases when the patient exhales, allowing for easier exhalation. Complications of non-invasive ventilation include facial and nasal injury and skin breakdown, dry mucous membranes and thick secretions, and aspiration of gastric contents if vomiting occurs. Complications avoided by non-invasive ventilation are VAP, sinusitis, and effects of large-dose sedative agents. Use of non-invasive ventilation 898 results in shorter intensive care unit, ICU, and hospital stays, Suhu et al., 2014. Perform good oral hygiene every few hours while a patient is on BiPAP to relieve dryness. Chest tubes. A chest tube, Figure 41 to 15, is a catheter inserted through the thorax to remove air and fluids from the pleural space, to prevent air or fluid from re-entering the pleural space, or to re-establish normal intrapleural and intrapulmonic pressures. Baumann et al., 2011. Chest tubes are common after chest surgery and chest trauma and are used for treatment of pneumothorax or hemothorax to promote lung re-expansion. See Skill 41 to 3 on pages 922 to 926. Figure 41 to 15 chest tube placement. A pneumothorax is a collection of air in the pleural space. The loss of negative intrapleural pressure causes the lung to collapse. There are a variety of causes for a pneumothorax. A secondary pneumothorax can occur as a result of chest trauma, example stabbing, gunshot wound, or rib fracture from striking the chest against the steering wheel in an automobile accident. Other causes of secondary pneumothorax are the rupture of an emphysema tube lobe on the surface of the lung, the destruction caused by emphysema, tearing of the pleura from an invasive procedure such as surgery, insertion of a subclavian 4-line, and invasive mechanical ventilation, including PEEP. Spontaneous, primary, pneumothorax is a genetic condition that occurs unexpectedly in healthy individuals who develop blister-like formations, blebs, on the visceral pleura, usually on the apex of the lungs. The blebs can rupture during sleep or exercise. McCants and Huther, 2014. A patient with a pneumothorax usually feels pain as atmospheric air irritates the parietal pleura. The pain is sharp and pleuritic and worsens on inspiration. Dyspnea is common and worsens as the size of the pneumothorax increases. A hemothorax is an accumulation of blood and fluid in the pleural cavity between the parietal and visceral pleura, usually as a result of trauma. It produces a counterpressure and prevents the lung from full expansion. A rupture of small blood vessels from inflammatory processes such as pneumonia or TB can cause a hemothorax. In addition to pain and dyspnea, signs and symptoms of shock develop if blood loss is severe. A variety of chest tubes are available to drain air or excess fluid from the pleural space to relieve respiratory distress. A small bore chest tube, 12 to 20 fr, is used to remove a small amount of air, and 899 larger bore chest tube is used to remove large amounts of fluid or blood and large amounts of air. Carroll, 2015. After a chest tube is inserted, it is attached to a drainage system. A traditional chest drainage unit, CDU, has 3 chambers for collection, water seal, and suction control. This unit can drain a large amount of both fluid and air. Carroll, 2015. Mobile systems rely on gravity, not suction, for drainage. In selected patients, these mobile drains reduce the length of time needed for the chest tube, improve ambulation, and decrease the length of time in the hospital. Carroll, 2015. Non-ventilated patients and patients who had thoracoscopic lung surgery or minimally invasive cardiac surgery do well with these mobile chest drains. They are lighter and smaller, thus patients are able to move more easily. As a result, this reduces the risks of deep vein thrombosis and pulmonary embolism. The simplest closed drainage system is the single chamber unit. The chamber serves as a fluid collector and a water seal. During normal respiration, the fluid in the chamber ascends with inspiration and descends with expiration. A single chamber is used for smaller amounts of drainage such as an empyema, example a collection of infected fluid or pus in the pleural space. The use of 2 chambers permits any fluid to flow into the collection chamber as air flows into the water seal chamber. Fluctuations in the water seal tube are still anticipated. 2 chambers allow for more accurate measurement of chest drainage and are used when larger amounts of drainage are expected. When a volume of air or fluid needs to be evacuated with controlled suction, all 3 chambers are used. Mark the suction control with centimeter readings to adjust the amount of suction. Usually 15 to 20 centimeters of water is used for adults. Carroll, 2015. This means that the chamber is filled with sterile water to the 15 or 20 centimeters water level. There is a new dry chest drainage system that does not use water in the suction chamber. An automatic control valve, ACV, is located inside the regulator and continuously balances the force of the suction with the atmospheres. As a result, the ACV responds and adjusts to changes in patient air leaks and fluctuations in suction source vacuum to deliver accurate suction. Set the pressure between 10 cm H2O and 40 cm H2O, RDC, 2011. Regardless of the system used, the principles of patient management are the same. Special considerations. Keep a chest tube system closed and below the chest, see Skill 41 to 3. The tube should be secured to the chest wall. Watch for slow, steady bubbling in the suction control chamber and keep it filled with sterile water at the prescribed level. Make sure that the water seal chamber is filled to the manufacturer specified level and watch for fluctuation, tidling, of the fluid level to ensure that the chest tube and system are working. A constant or intermittent bubbling in the water seal chamber indicates a leak in the drainage system, and the healthcare provider must be notified immediately. Mark the level on the outside of the collection chambers every shift. Report any unexpected cloudy or bloody drainage. Do not let the tubing kink or loop, and ideally it should lie horizontally across the bed or chair before dropping vertically into the drainage device. Encourage your patient to cough, deep breath, and use the incentive spirometer. Make sure that he or she is frequently repositioned and ambulated if not contraindicated. Routinely evaluate respiratory rate, breath sounds, SpO2 levels, and the insertion site for subcutaneous emphysema, RDC, 2011, Carroll, 2015. Clamping a chest tube is contraindicated when ambulating or transporting a patient. Clamping can result in a tension pneumothorax. Air pressure builds in the pleural space, collapsing the lung and creating a life-threatening event. A chest tube is only clamped when replacing the chest drainage system, assessing for an air leak, or during removal. Baumann et al., 2011. Chest tubes are not routinely stripped or milked to move clots or increase chest tube drainage. Baumann et al., 2011. Stripping or milking chest tubes is based on nursing assessment. See Skill 41-3. Handle the chest drainage unit carefully and maintain the drainage device below the patient's chest. If the tubing disconnects from the drainage unit, instruct the patient to exhale as much as possible and to cough. This maneuver rids the pleural space of as much air as possible. Temporarily re-establish a water seal by immersing the open end of the chest tube into a container of sterile water. Baumann et al., 2011. Removal of chest tubes requires patient preparation. The most frequent sensations reported by patients during chest tube removal include burning, pain, and a pulling sensation. Make sure that the patient is given pain medication at least 30 minutes before removal. 900 The nurse assists the healthcare provider in removing the chest tube and monitors the dressing placed over the insertion site and the patient's respiratory status after tube removal. Maintenance and promotion of oxygenation. Promotion of lung expansion, mobilization of secretions, and maintenance of a patent airway assist patients in meeting their oxygenation needs. However, some patients also require oxygen therapy to keep a healthy level of tissue oxygenation. Oxygen therapy. Oxygen therapy is widely available and used in a variety of settings to relieve or prevent tissue hypoxia. The goal of oxygen therapy, AARC, 2007, is to prevent or relieve hypoxia by delivering oxygen at concentrations greater than ambient air, 21%. Oxygen has dangerous side effects such as oxygen toxicity. The dosage or concentration of oxygen is monitored continuously. Routinely check the healthcare provider's orders to verify that the patient is receiving the prescribed oxygen concentration. The 6 rights of medication administration also pertain to oxygen administration, see Chapter 32. Supplemental oxygen therapy offers many benefits to patients with chronic cardiopulmonary diseases. This therapy reduces mortality, improves self-reported sleep quality and general comfort, increases exercise tolerance, and reduces polycythemia and pulmonary hypertension. Ernest, 2002. Patients may have continuous supplemental oxygen prescription or nocturnal oxygen supplements. In some situations, supplemental oxygen therapy is prescribed to accompany physical therapy. There is evidence that supports the use of oxygen therapy in these situations improves patient participation in physical therapy, improves activity tolerance, reduces the time needed for extended or home care, and returns patient to maximal level of health. Task Force on Supplemental Oxygen Therapy, 2014. It is important to reinforce to your patients why they may have supplemental oxygen during physical therapy but have supplemental oxygen full-time. Box 41-9. Safety precautions. Oxygen is a highly combustible gas. Although it does not burn spontaneously or cause an explosion, it can easily cause a fire in a patient's room if it contacts a spark from an open flame or electrical equipment. With increasing use of home oxygen therapy, patients and healthcare professionals need to be aware of the dangers of combustion. Cassis et al., 2014. Chapter 27 describes steps to take in case of fire. Promote oxygen safety by the following measures. Oxygen is a therapeutic gas and must be prescribed and adjusted only with a healthcare provider's order. Distribution must 902 be in accordance with federal, state, and local regulations. AARC, 2007. Place an oxygen in use sign on the patient's door and in the patient's room. If using oxygen at home, place a sign on the door of the house. No smoking should be allowed on the premises. Keep oxygen delivery systems 10 feet from any open flames. Determine that all electrical equipment in the room is functioning correctly and properly grounded. See Chapter 27. An electrical spark in the presence of oxygen can result in a serious fire. When using oxygen cylinders, secure them so they do not fall over. Store them upright and either chained or secured in appropriate holders. Check the oxygen level of portable tanks before transporting a patient to ensure that there is enough oxygen in the tank. Ensure that patients have adequate oxygen tubing to safely move around their home environment. Tubing up to 98 feet, 30 m, will deliver the prescribed oxygen flow rate. Aguiar et al., 2015. Supply of oxygen. Oxygen is supplied to a patient's bedside either by oxygen tanks or through a permanent wall pipe system. Oxygen tanks are transported on wide-based carriers that allow the tank to be placed upright at the bedside. Regulators control the amount of oxygen delivered. One common type is an upright flow meter with a flow adjustment valve at the top. A second type is a cylinder indicator with a flow adjustment handle. In the hospital or home, oxygen tanks are delivered with the regulator in place. In the hospital, the respiratory care department usually connects the regulator to the oxygen source. Home care vendors are usually responsible for connecting the oxygen tank to the regulator for home use. Methods of oxygen delivery. The nasal cannula and oxygen masks are the most common devices to deliver oxygen to patients. These devices deliver different levels of oxygen to patients. Table 41-7. Table 41-7. Oxygen delivery systems. Delivery system. FiO2 delivered. Advantages. Disadvantages. Low flow delivery devices. Nasal cannula. 1 to 6L/min, 24%-44%. Safe and simple. Easily tolerated. Effective for low concentrations. Does not impede eating or talking. Inexpensive, disposable. Unable to use with nasal obstruction. Drying to mucous membranes. Can dislodge easily. May cause skin irritation or breakdown around ears or nares. Patient's breathing pattern, mouth or nasal, affects exact FiO2. Simple face mask. 6 to 12 L/min, 35%-50%. Useful for short periods such as patient transportation. Contraindicated for patients who retain CO2. May induce feelings of claustrophobia. Therapy interrupted with eating and drinking. Increased risk of aspiration. Partial and non-rebreather masks. 10 to 15 L/min, 60%-90%. Useful for short periods. Delivers increased FiO2. Easily humidifies O2. Does not dry mucous membranes. Hot and confining, may irritate skin, tight seal necessary. Interferes with eating and talking. Bag may twist or kink, should not totally deflate. Oxygen conserving cannula, oximizer. 8 L/min, up to 30%-50%. Indicated for long-term O2 use in the home. Allows increased O2 concentration and lower flow. Cannula cannot be cleaned. More expensive than standard cannula. High flow delivery devices. Venturi mask. 24%-50%. Provides specific amount of oxygen with humidity added. Administers low, constant O2. Mask and added humidity may irritate skin. Therapy interrupted with eating and drinking. Specific flow rate must be followed. CO2, carbon dioxide, FiO2, fraction of inspired oxygen concentration. Nasal cannula. A nasal cannula is a simple, comfortable device used for precise oxygen delivery. The two nasal prongs are slightly curved and inserted in a patient's nostrils. To keep the nasal prongs in place, fit the attached tubing over the patient's ears and secure it under the chin using the sliding connector. Be alert for skin breakdown over the ears and in the nostrils from too tight an application. Attach the nasal cannula to a humidified oxygen source with a flow rate up 1 to 6 L/min, 24% to 44% oxygen. Flow rates equal to or greater than 4 L/min have a drying effect on the mucosa and thus need to be humidified. AARC, 2007. Know which flow rate produces a given percentage of inspired oxygen concentration, FiO2. Oxygen masks. An oxygen mask is a plastic device that fits snugly over the mouth and nose and is secured in place with a strap. It delivers oxygen as the patient breathes through either the mouth or nose by way of a plastic tubing at the base of the mask that is attached to an oxygen source. An adjustable elastic band is attached to either side of the mask that slides over the head to above the ears to hold the mask in place. There are two primary types of oxygen masks, those delivering low concentrations of oxygen and those delivering high concentrations, see box 41-9. The simple face mask, figure 41-16, is used for short-term oxygen therapy. It fits loosely and delivers oxygen concentrations from 6 to 12 L/min, 35% to 50% oxygen. The mask is contraindicated for patients with carbon dioxide retention because retention can be worsened. Flow rates should be 5 L or more to avoid rebreathing exhaled carbon dioxide retained in the mask. Be alert to skin breakdown under the mask with long-term use, Downey et al., 2013. Figure 41-16 simple face mask. A plastic face mask with a reservoir bag is capable of delivering higher concentrations of oxygen. A partial rebreather or non-rebreather mask is a simple mask with a reservoir bag that should be at least 1/3 to 1/2 full on inspiration and delivers a flow rate of 10 to 15 L/min, 60% to 90% oxygen. Frequently inspect the reservoir bag to make sure that it is inflated. If it is deflated, the patient is breathing large amounts of exhaled carbon dioxide. High-flow oxygen systems should be humidified, AARC, 2007. The Venturi mask delivers higher oxygen concentrations of 24% to 60% and usually requires oxygen flow rates of 4 to 12 L/min, depending on the flow control meter selected. Home oxygen therapy. Indications for home oxygen therapy include an arterial partial pressure, PAO2, of 55 mm Hg or less or an arterial oxygen saturation, SAO2, of 88% or less on room air at rest, on exertion, or with exercise, American Thoracic Society, 2011. Home 903 oxygen therapy is administered via nasal cannula or face mask. Patients with permanent tracheostomies use either AT tube or tracheostomy collar, AARC, 2007. Home oxygen therapy has beneficial effects for patients with chronic cardiopulmonary diseases. This therapy improves patients' exercise tolerance and fatigue levels and in some situations assists in the management of dyspnea, see skill 41-4. There are three types of oxygen delivery systems, compressed gas cylinders, liquid oxygen, and oxygen concentrators. Before placing a certain delivery system in a home, assess the advantages and disadvantages, table 41-8, of each type, along with the patient's needs and community resources. In the home, the major consideration is the oxygen delivery source. Table 41-8. Home oxygen storage systems. Primary use. Advantages. Disadvantages. Compressed gas cylinders. Stationary and portable systems designed for intermittent therapy such as for exercise or sleep or as a backup system for a concentrator only. 100% oxygen stored in steel or aluminum cylinders, relatively inexpensive, no loss of gas during storage, relatively portable, delivery of up to 15 L/min, does not require electrical source, smaller tanks available for portability. Bulky and heavy, must be secured safely to prevent them from falling over, frequent refilling necessary with continuous use, patient must know how to read regulator and understand when to call supplier, portable cylinders weigh 15 pounds. Liquid oxygen systems. Stationary and portable system of choice for high-volume users and active patients. 100% oxygen, more oxygen occupies a smaller space, patient carries convenient ambulatory units refilled at home as shoulder bag, backpack, or wheeled luggage cart, delivery of up to 6 L/min, they come with a battery pack or electrical connections for cars, patient can safely refill ambulatory units from larger reservoir, quiet and easy operation, minimal maintenance, does not require electricity for operation, requires relatively fewer deliveries of oxygen. Evaporates, especially in warmer temperatures and when not in use, potential for connections to freeze together or form frost at connections if tight connection not maintained during filling, costly setup and delivery fees. The liquid oxygen is very cold and can harm the skin instantly upon contact. Oxygen concentrators. Stationary system, cost-effective for patients requiring low-flow continuous oxygen and patients with limited mobility inside or outside the home. Provide a large source of oxygen, inexpensive, fixed monthly costs, most units with delivery of 1 to 5 L/min, good choice for people who do not leave their homes frequently, no cylinders or tanks to refill, delivery up to 10 L/min with specific makes and models. They must be placed in an open, well-ventilated area away from heat and flames. They work by removing nitrogen from room air to make the air 94% to 98% oxygen. They can be small and can weigh from 22 to 70 pounds. Oxygen concentration decreases as liter flow increases, power supply needed, increased electric costs, is not an ambulatory unit, therefore requires second system for portability, requires regular maintenance and backup system. Compressed gas. Small cylinders with compressed gas that allow for portability. Different models allow from 1 to 5 hours of portable oxygen. Cylinders can be easily wheeled on a cart or a stroller. Smaller tanks can be carried in backpacks, fanny packs, or shoulder bags. Each cylinder is fitted with a regulator used for adjusting the flow rate. At a rate of 2 L/min, they last only a few hours. The most common cylinder used is the E cylinder, it lasts about 5 hours at a rate of 2 L/min. They only last a few hours. E cylinders are not appropriate as a sole source of oxygen for continuous, long-term therapy. The COPD Foundation. Patients and their family caregivers need extensive teaching to be able to manage oxygen therapy efficiently and safely. See Skill 41-4 on pages 927 to 929. Teach the patient and family about home oxygen delivery, example oxygen safety, regulation of the amount of oxygen, and how to use the prescribed home oxygen delivery system to ensure their ability to maintain the oxygen delivery system. The home health nurse coordinates the efforts of the patient and family, home respiratory therapist, and home oxygen equipment vendor. The social worker usually assists initially with arranging for the home care nurse and oxygen vendor. QSEN. Restoration of cardiopulmonary functioning. If a patient's hypoxia is severe and prolonged, cardiac arrest results. A cardiac arrest is a sudden cessation of cardiac output and circulation. When this occurs, oxygen is not delivered to tissues, carbon dioxide is not transported from tissues, tissue metabolism becomes anaerobic and metabolic, and respiratory acidosis occurs. Permanent heart, brain, and other tissue damage occur within 4 to 6 minutes. Cardiopulmonary resuscitation. During cardiac arrest there is an absence of pulse and respiration. The American Heart Association continues to research cardiac arrest treatment and outcomes. The 2010 Consensus Conference reviewed the most current and comprehensive resuscitation literature/research to develop the 2010 AHA guidelines for cardiopulmonary resuscitation, CPR, and emergency cardiac care, ECC, thus simplifying the basic life support, BLS, steps, AHA, 2010b. 904. The previous ABC, establish an airway, initiate breathing, and maintain circulation, of cardiopulmonary resuscitation, CPR, is changed to CAB, chest compression, airway, breathing, for adults and pediatric patients, excluding newborns. In adults, the majority of cardiac arrests, the critical initial elements found to be essential for survival were chest compressions and early defibrillation. Ventilation is done after the first cycle of 30 chest compressions. In addition, the AHA, 2014, has set a goal for hospitals to deliver the first electrical shock to patients in ventricular fibrillation in less than 2 minutes. Another issue is that bystander CPR may increase if those not comfortable with doing ventilations would at least perform chest compression. For most adults without of the hospital arrest, hence only CPR by bystanders has had similar outcomes to conventional CPR. A lone healthcare provider who sees an adult in cardiac arrest should activate the emergency response system, get and use an automatic external defibrillator, AED, if available, and give CPR. Defibrillation by AED, box 41-10, is needed to stop an abnormal heart rhythm, and AEDs are now available in public places such as schools, airports, and workplaces. AHA, 2006, 2010a, b. Box 41-10. Automated external defibrillator. The automated external defibrillator, AED, is a device used to administer an electrical shock through the chest wall to the heart to stop the abnormal rhythm and restore a normal heart rhythm. The AED has built-in computers that assess patients' heart rhythm and determine if defibrillation is necessary. New technology has made them user-friendly with audio and visual cues telling users what to do when using them. AHA, 2010b, 2011. The AED analyzes the patient's heart rhythm and determines if a shock is needed. It delivers a shock to the patient after announcing, "Everyone stand clear of patient." A shock is only delivered if the patient needs it. Lay rescue or AED programs train lay personnel, security guards, police, and firefighters on the use of the AED. AHA, 2006, 2010b, 2011. The AED is used to strengthen the chain of survival. Every minute of a sudden cardiac arrest without defibrillation decreases the survival rate by 7% to 10%. AHA, 2011. For witnessed ventricular fibrillation, early cardiopulmonary resuscitation with defibrillation within the first 3 to 5 minutes can result in greater than 50% long-term survival. AHA, 2010a. Restorative and continuing care. Restorative and continuing care emphasizes cardiopulmonary reconditioning as a structured rehabilitation program. Cardiopulmonary rehabilitation helps patients achieve and maintain an optimal level of health through controlled physical exercise, nutrition counseling, relaxation, and stress management techniques, and prescribed medications and oxygen. As physical reconditioning occurs, a patient's complaints of dyspnea, chest pain, fatigue, and activity intolerance decrease. In addition, the patient's anxiety, depression, or somatic concerns often decrease. The patient and the rehabilitation team define the goals of rehabilitation. Respiratory muscle training. Respiratory muscle training improves muscle strength and endurance, resulting in improved activity tolerance. Respiratory muscle training prevents respiratory failure in patients with COPD. One method for respiratory muscle training is the incentive spirometer resistive breathing device, ISRD. Patients 905 achieve resistive breathing by placing a resistive breathing device into a volume-dependent incentive spirometer. Patients achieve muscle training when they use the ISRD on a scheduled routine, example twice a day for 15 minutes or 4 times a day for 15 minutes. Breathing exercises. Breathing exercises include techniques to improve ventilation and oxygenation. The 3 basic techniques are deep breathing and coughing exercises, pursed lip breathing, and diaphragmatic breathing. Deep breathing and coughing exercises, previously discussed, are routine interventions used by postoperative patients, see Chapter 50. Pursed lip breathing. Pursed lip breathing involves deep inspiration and prolonged expiration through pursed lips to prevent alveolar collapse. While sitting up, instruct the patient to take a deep breath and exhale slowly through pursed lips as if blowing through a straw. Have him or her blow through a straw into a glass of water to learn the technique. Patients need to gain control of the exhalation phase so it is longer than inhalation. The patient is usually able to perfect this technique by counting the inhalation time and gradually increasing the count during exhalation. In studies using pursed lip breathing as a method to improve exercise tolerance in patients with COPD, patients were able to demonstrate increases in their exercise tolerance, breathing pattern, and arterial oxygen saturation. Cabral et al., 2014. Diaphragmatic breathing. Diaphragmatic breathing is useful for patients with pulmonary disease, postoperative patients, and women in labor to promote relaxation and provide pain control. The exercise improves efficiency of breathing by decreasing air trapping and reducing the WAB. Diaphragmatic breathing is more difficult than other breathing methods because it requires a patient to relax intercostal and accessory respiratory muscles while taking deep inspirations, which takes practice. The patient places one hand flat below the breastbone, upper hand, and the other hand, lower hand, flat on the abdomen. Ask him or her to inhale slowly, making the abdomen push out. As the diaphragm flattens, the abdomen should extend out, and moving the lower hand outward. When the patient exhales, the abdomen goes in, the diaphragm ascends and pushes on lungs to help expel trapped air. The patient practices these exercises initially in the supine position and then while sitting and standing. The exercise is often used with the pursed lip breathing technique. Evaluation. Evaluate nursing interventions and therapies by evaluating if patient expectations have been met and by comparing the patient's progress with the goals and expected outcomes of the nursing care plan, Figure 41-17. Figure 41-17 Critical Thinking Model for Oxygenation Evaluation. Through the patient's eyes. It is important to